presenter, just unmute and come for presentation. Somebody in the topic, I think. Please unmute, mute all of you, please mute. Sriharsha?
I'm unmuting, sir. All.
Unmuting all, please unmute all.
Ramesh, Sudeep.
Sir, sir. Good afternoon, sir. Welcome, sir.
Good afternoon.
Yeah, just 1 minute, sir.
Okay.
Harsha will unmute mute everyone. Only host will talk. Sriharsha?
Muted all, sir.
Yeah. So before that, Sriharsha, please read out the technical issues once.
Carry on introduction, sir. I need 5 minutes.
Still, there is a lot of noise. I request once again, only presenter will talk. Unmute and talk. So welcome all the postgraduates for this virtual session. This is now today we are starting with Dr. Dwarakanath Reddy sir medal for best case series. I welcome Dr. Sudeep sir, honorary president of AOI Telangana, to give a welcome note.
Thank you, Ramesh. Good morning, all the delegates, postgraduates, judges for the 7th state conference, and all the postgraduates. Wish you all the very best, and be very confident and be very lucid, and wish you all the very best. And thank you all the judges for being here, to be taking a valuable time out to be judging these papers. Thank you, sir. Thank you, one and all, and a warm welcome to this state conference. Manoj.
Thank you, Sudeep sir.
Thank you. Thank you, Ramesh.
Yeah. For this session, I'm inviting Dr. M. Vishnuvardan Reddy sir and Dr. M. Subbarao sir as the chairpersons for this session. Welcome to Vishnuvardan Reddy sir. Sir is the retired professor and HOD of Usmania Medical College, and Dr. M. Subbarao sir, the professor and HOD of Medicity Medical College. Sir, are you there, sir? Vishnuvardan Reddy sir?
Yeah,
Subbarao sir.
Yeah, I'm
yes,
available.
Most welcome, sir.
Yeah. Good luck to all.
Yeah, this is the session for case series presentation, sir. There are 28 candidates are there. First 14 candidates will judge up to this session go up to from 2 p.m. to 4:30, sir. I'm welcoming the judges from Karnataka State, Dr. Anil Kumar, sir.
Good afternoon, sir.
Yeah, most welcome, sir. Dr. Sriharsha. Dr. Sriharsha.
Sir.
Please play the CV, Dr. Anil Kumar sir CV. Please show that, share that.
Sir, welcome Dr. Anil Kumar, sir. He is Associate Professor in Department of ENT from Bangalore Medical College and Research Institute. He has a total professional experience, teaching experience of 25 years. and he's been UG teacher since 2008. He has guided a lot of postgraduates since 2008. We welcome you to the AOI virtual series, sir. Welcome, sir.
Thank you, sir.
Thank you, Anil sir, for kind acceptance. And I welcome Dr. Nagaraj sir from Bangalore. Harsha? Nagaraj sir, CV ready?
We would like to welcome Dr. Nagaraj sir to the session. He is a professor in ENT in MVG Medical College and Research Hospital, Bangalore. He has a UG teaching experience since 18 years and also PG teaching experience since 10 years. Welcome you, sir.
Thank you, Harsha. So, sir may join in 1 or 2 minutes. It's technical delay. Before that, I want to read out the once again guidelines of Dr. Dwarkanath Reddy sir medal for case series. There are 8 minutes for presenter. They have to present up to 8 minutes. If anybody goes beyond, there is no questions from the judges. Please be maintained. Strictly adherent to 8 minutes. There will be a warning bell by 7 minutes. After 8 minutes, you have to stop. So second bell. Okay, Dr. Manoj, are you there?
Yes, sir.
Dr. Manoj is the coordinator for this entire session, starting from 1st to 14th. Okay, first Dr. Lakshmi Nair is there. Are you ready, Dr. Lakshmi Nair?
Sir, am I audible?
Yeah, you're audible.
Yes, sir.
Yeah, so you have to maintain the timings. Okay.
Yes, sir.
Yeah, just wait for 2 minutes. Just wait for 2 minutes. Meanwhile, you get ready with your presentation.
Okay.
Our next judge will join. Once I confirm, you just start the presentation. Sriharsha? Good afternoon, Nagaraj sir.
Yeah, good afternoon, sir.
Warm welcome, sir.
Oh,
Just now we heard read about your CV, sir.
okay, sir.
Shall we go ahead, sir?
Yes, sir. You can go ahead, sir.
Yeah, with the permission of the chairpersons and judges, we'll start, sir. Sir,
Okay.
Vishwanath Reddy sir and Subbarao sir, shall we start?
Okay, sir. No problem.
Yes, please.
Yeah, please be on time, sir. This is strictly 8 minutes. If they present within 8 minutes only, they will get the good score. And questions will be asked by the judges. If they spare the time, then only they will ask the questions. Okay, this is 8 minutes time only, sir. Yeah, Dr. Lakshmi Nair, are you ready? Dr. Manoj, you can go ahead.
Yes, sir.
You can go ahead. You get ready with your timer.
Okay, sir.
Yeah.
Timer is ready.
Lakshmi Nair, what happened?
Sir, is my presentation visible?
Now, why you are taking too much of time? Yesterday, 2 days before we have conducted trial run also. Okay, your time starts. Okay. I request other presenters be ready, and who have presented, please leave this link. And we have given a YouTube link. You can join the YouTube link and watch the presentations. Okay, Manoj?
Sir?
Yeah, you go ahead. Time will count now itself. Okay, don't
Yes,
waste
sir.
time.
I'm starting the timer.
Yes, right.
Good evening. This is a case on mucous paranasal. So the study was, this is a clinical, it's a retrospective kind of clinical study. And in this study, we have looked age group, finding the and post-op recovery of patients who presented to our center with mucosal paranasal sinus. So the source of data is the cases attending tertiary care center from the time period of June 22 to August 2022. So in inclusion criteria, we have included patients who have their willingness to study. Any age were taken to study, and clinical are consistent with mucosal. Exclusion criteria, we have included patients who have not given their consent to study. So over a period of 3 months, patients presented with clinical features of mucosals were identified and the following parameters were evaluated. For the first age group, then the second patient, the duration of onset of its symptoms, and the most commonly involved sinus, the clinical presentation, the surgical treatment. So when we studied the age group, in this we found of the 10 patients, 4 patients belong to the age group of 10 to 20 years, 4 patients in the age group of 20 to 30 years, and 2 patients were found in the age group of 40 to 50 years. So we concluded that age mostly is, at least in the 10 patients that we have studied, the age where it is more predominant in the younger age group. Sex, 40% were females and 60% patients were found to be males. So it is a more of male predilection was seen during the study. The duration of onset, 15 to 30 days within the onset of within 15 to 30 days of clinical symptomatology. 6 patients seek medical advice, and patients, that is 4 patients had a more indolent onset of the symptoms that they came for medical attention only after 30 to 45 days. Then the most commonly involved sinuses, we found study 50% of cases have sinus involvement, 30% of cases had frontal sinus involvement, 10% cases had sinus, and 10% of cases had maxillary sinus involvement. With respect to clinical symptoms, we studied ptosis, swelling, blurred vision, and diplopia. We found that invariably all cases had proptosis as one of the clinical symptoms. 9 cases had swelling in and around the orbit, which changed based on which sinus was involved. 1 patient had blurred vision and diplopia. So in medical management, by using broad spectrum antibiotics were given, supportive was given. The main management was surgery, where we used endoscopic approach. So just clinical pictures of a few relevant cases. This is the case of frontal mucosal. The 28-year-old male patient, he presented with the left eye proptosis and swelling around the medial canthus of the left eye. A 28-year-old female, she presented with swelling of the eye And in CT scan, we found a mass, a cystic swelling, which is posterior to the maxillary sinus, and it was identified to be sphenoid mucosal. A 16-year-old female presented with right eye proptosis and medial swelling on the medial canthus of the right eye. She was found to have frontoethmoid mucosal. So to conclude, the mucosal basically expansile growth seen due to chronic collection of inspissated mucus inside the glands. So basically, it's a dilatation of the glands inside the sinus. And many times, patients will have history of trauma or nose surgery. So causes are trauma, scarring, and inflammation. Some patients might not even have a history of trauma. So in symptoms includes swelling in and around the orbit, proptosis, blurring of vision, diplopia. So in CT scan, we'll have a well opacified lesion, it's homogeneous, and it thins out the body margins around it. Treatment mainstay of management is surgical, and the technique used is mucosal mucus. So mucosals can give rise to complications if for example, frontal mucosal, if it is involving the posterior table, it can lead to meningitis, epidural abscess, subdural empyema, cerebral, etc. Thank you.
What is the follow-up protocol?
Sir, we'll follow up the patient with a routine diagnostic nasal endoscopy, sir, in every 3 weeks.
When will you do the repeat scan? What is the protocol for repeat scans?
Sir, after 3 months.
Every 2 years, and you have to follow it up for up to 5 years. What is the etiology?
Sir, cause of this is mostly trauma or a history of nose surgery in the past, because of which the glands will get dilated with the secretions inside.
What is the theories attributed to the expansion of these mucosals?
I'll read it.
What happens to the bone?
Demineralization of the bone will happen, sir, because of the pressure effect.
Shall I call the next candidate, sir?
Okay, sir.
Thank you.
Next, Dr. Anju from OMC.
Finally, it is done. Hi.
Start your case.
Good afternoon, sir.
Yeah, good afternoon. Go ahead.
Sir, is my screen visible?
Yeah.
Sir, can I start now?
Start the series.
Okay, sir. Good afternoon, everyone. I'm presenting radiological findings in patients undergoing revision endoscopic sinus surgery, a retrospective case study. Introduction. A functional endoscopic sinus surgery has become a well-established strategy for the treatment of rhinosinusitis not responding to maximal medical treatment. A patient with persistent chronic sinusitis or recurrent infections after a primary sinus surgery needs a suitable treatment with antibiotics and steroids. If despite sufficient medical treatment, the patient's symptoms persist, a CT scan is obtained to identify the cause of infection. Once an anatomical etiology of primary surgery failure is identified, a revision surgery is usually indicated. A retrospective descriptive study was conducted in a tertiary ENT care center where the axial and coronal CT scan of about 20 patients admitted for revision FIS between January 2022 and August 2022 were retrospectively studied. All patients presented with symptoms and endoscopic findings of recurrent sinusitis that did not respond to maximal medical. The results included the patients' ages ranged from 20 to 65 years with mean age of 35 years. There were about 11 males and 10 females. The data collected included identification of significant septal deviation, lateralized middle turbinate, residual uncinate process, residual HALA cells, residual anterior and posterior ethmoidal cells. Coming to the statistics, there was about 12% middle turbinate lateralization found. That means about 5 out of 40 sites of middle turbinate was lateralized. There was residual septal deviation in 15%, residual uncinate process in about 27.5%, that is about 11 out of 40 sites. Residual infraorbital cells in about 17.5%, 10% residual anterior ethmoidal cells, and 12.5% residual posterior ethmoid cells. This pie chart is showing the incidence of each in the 20 patients. 30% of residual uncinate process, septal deviation in 15%, middle turbinate lateralization in about 25%, residual HALA cells in about 25%, residual anterior ethmoidal cells in 20%, and 15% of residual posterior ethmoidal cells. This is an axial CT scan image showing the residual septal deviation. A coronal CT image showing residual septal deviation to left side. Again, a coronal CT image showing right residual uncinate process. A coronal CT image showing lateralized right middle turbinate. Again, a coronal CT image showing left side infraorbital residual cell, which is blocking the left osteomeatal complex. This is a CT image, a coronal CT image showing residual anterior ethmoidal cell. The same is shown in the axial cut. According to Lund-Mackay, the mucosal disease of the paranasal sinuses and the osteomeatal complex was scored, where a sinus with no opacification is given a score of 0, with partial opacification is given a score of 1, with full opacification is given a score of 2. A patent osteomeatal complex is given a score of 0, while a blocked one is given a score of 2. Coming to the statistics, in my study, there were about 35% with no opacification and 65% with full opacification. Coming to the maxillary sinus, there was partial opacification in 67.5, 60% of partial opacification in anterior ethmoidal cells, and 75% of partial opacification in posterior ethmoidal cells. Coming to the pie chart, we can see that there was about 65% of partial opacification of maxillary sinus, 12.5 full opacification, and 17.5 no opacification. While 65% there was blocked osteomeatal complex, while there was patent 35%. This is a coronal CT image showing full opacification of right maxillary and right anterior ethmoidal cells. Coming to the discussion, several reasons have been identified for the failure of primary endoscopic sinus surgery. Revision surgery is considered to be more difficult to perform since there might be missing anatomical landmarks, an increase in bleeding, and the presence of adhesions. Fibrosis and adhesion formation, particularly between the middle turbinate and the lateral nasal wall, was the most common intraoperative findings. In my study, the most common anatomical factors associated with the primary surgery failure was a residual and uncinate process. while the result also showed about 25% lateralized middle turbinate. Coming to the other studies by Musay and Kontakis, their most common anatomical factor was a lateralized middle turbinate, where it occurred in about 78% of their patients. Their results also showed residual anterior ethmoidal cells in about 64%, residual posterior ethmoidal cells in about 41%, and residual agernasal cells in about 49%. Lasser also found that fibrosis in adhesion was the most common cause for a primary surgery failure. Recurrence of polyp was the second most common finding in the study. In another study by Ramdan, the most common anatomical finding during a revision phase was adhesion, often involving a lateralized middle turbinate. A preoperative imaging is vital in any planned phase, but even becomes more important in the case of revision. Axial and coronal images are vital for evaluating danger areas like the ethmoidal roof, position of optic nerve and carotid
1
artery,
minute left.
presence of sphenoid air cells, and the integrity of lamina papricia. The recurrence of chronic rhinosinusitis that needs revision phase is multifactorial. The analysis of CT scans of patients undergoing revision phase demonstrate persistent anatomical structures and non-dissected cells. This study demonstrated a number of frequent anatomical and subsequent pathophysiological findings encoded at revision surgery. More trials of studies with a larger number of patient series comparing the anatomical variation that impact on recurrence of CRS with and without polyp are required. These are my references. Thank you.
Will you counsel the patient for revision phase? What is the important point you will tell?
There was a residual anatomical factor that is present, which we need to clear so that maximal, again, if you give a medical therapy.
You should counsel about post-op care. That is very important. Post-op care is very important. Okay. Yeah. Next.
I request a candidate, please on your video while you are presenting and while you are facing the questions. Manoj?
Yes, sir.
Next candidate, and ask them to show their video.
Sir, please turn on your video. Next candidate, Dr. Bharat Kumar from Chelmeda. Start your presentation.
Good afternoon, sir. The topic is oral submucosal fibrosis. Is it a collagen disease? A study in search for its etiology. Introduction. Oral submucosal fibrosis, though prevalent through Indian subcontinent, its etiopathogenesis is still an enigma. The disease frequently leads to severe trismus and ankyloglossia. Most of the patients with oral submucosal fibrosis have the complaint of long-standing, gradually progressive, painless difficulty in opening the mouth, which is trismus, and followed of fibrosis of the soft palate and buccal region. Other common features include recurrent vesicles and ulceration in oral cavity and oropharynx. The leading and well-reported and accepted predisposing factor of oral submucosal mucous fibrosis is chewing of different forms of betel nuts, betel leaves, and tobacco. As the exact cause of the disease is yet not certain, there is no well-accepted and effective treatment. Aim of the study. Aim of the study is to find out some definitive causative features so that an effective treatment regime could be evolved. Materials and methods. Study design. It is a prospective observational study. Study selection. outpatient at ENT department. Study period is around 12 months. Sample size 110 subjects were included in this prospective and observational study. Inclusion criteria. All the patients with oral submucosal mucous fibrosis present to the Department of ENT during the study period were enrolled for this study. Exclusion criteria. The patients who were not willing and did not give their informed consent were excluded from the study. Otherwise, there were no other exclusion factors. Observation and results. In majority of the cases, there were mild to moderate anemia was observed. Half of the cases showed raised ESR. Findings of other investigations are as shown in the table. Anemia is seen in 82.66%, raised ESR in 50%, eosinophilia in 32%, lymphocytosis in 28%, hyperglobulinemia in 30%, OI and cyst in the stool in 28%, pus cells in urine in 20%, leukocytosis in 12%, old tuberculosis X-ray chest are seen in 2%, and chronic bronchitis in X-ray is seen in 2%. Discussion. Collagen vascular disease is an autoimmune disease that affects the connective tissue, so also called connective tissue disease. Collagen, which has the greater tensile strength, is a protein-based connective tissue which is the main component of the tissues. The features suggestive of collagenous etiology of oral submucosal fibrosis observed in various studies is as follows. In this we have hyperglobulinemia, increased mononuclear cells, lymphoid and plasma cell infiltration, eosinophilia, increased in dense collagen, and hyaline degeneration of connective tissue. Dense hyalinized juxtaepithelial connective tissue showing metachromasia with alcohol told in blue and constricted blood vessels are seen. Finding which resemble scleroderma are bone marrow showing allergic reaction with hypercellularity and eosinophilia, raised levels of mucopolysaccharides and mucoprotein, raised anti-streptolysin O titer, and response to the steroids. Features found in the present study which suggestive of collagenous etiology of disease were as follows. Eosinophilia in 32%, serum hyperglobulinemia in 30%, association of the disease with scleroderma and leukoderma is 0.06%. Almost all the patients of the present study were exposed to chronic irritation of oral mucosa by acria nuts, but all of them do not suffer from oral submucosal fibrosis. So there might be some genetic factor which is causing an abnormal response to tissue trauma. However, these genetic factors are yet to be studied. Conclusion. Present study could not establish the commonly claimed theory of collagen disease because majority of the patient's etiology were found to be associated with chewing of acria nuts, tobacco and gutka. In some patients, genetic factors also seem to play a role. These are my references, sir. Thank you, sir.
Dr. Ramesh.
Sir, good afternoon, sir.
Good afternoon, Dr. Ramesh. I am Dr. Subara.
Sir, welcome, sir. Welcome, sir.
Sorry for late. Sorry
no
for
issue,
late.
sir. No issue, sir. Please be as a chairperson for this session, sir, along with Sir Vishwanath Reddy, sir.
Ramesh, I have two queries for you.
Sir.
So one is, who is announcing, don't announce the name of the college. Number
Okay,
one.
sir. Yes, yes.
And number two, is the questions are allowed after the presentation?
Questions allowed if they present within 8 minutes, sir. If they cross 8 minutes, no questions allowed, sir. I told earlier only, sir.
Okay. Okay.
Thank you, sir.
Thanks.
Dr. Manoj, don't announce the name of the college, just call the name. Call their name. Yes. Thank you, sir. Thank you for suggestion, sir.
Okay.
Yeah, go ahead.
Next presentation by Dr. Suman from Chelmeda.
Manoj, don't announce the names of the college. Okay, just now I
Yes, sir.
told you.
Yes, sir.
Not just name.
Okay, sir. Start your presentation, Dr. Suman.
Good afternoon, sir. My topic is conventional septoplasty versus endoscopic septoplasty, a comparative study. Introduction. The standard surgical treatment for symptomatic deviated septum is septoplasty. This is usually done conventionally by using the headline. However, in recent years, the endoscopic method has emerged as an alternative technique. Aim of the study. This study aims to compare results of conventional and endoscopic septoplasty. Material and methods. Study design is a prospective study. Selection in E&D patient department. Study period is 12 months. Sample size is 44 patients. Inclusion criteria. The patients, those who are having the symptoms of nasal obstruction. Patients age group more than 17 years. Exclusion criteria. Patients with the history of sinusitis and polyp. Patient with the history of previous nasal surgeries. Patients with an existing external nasal deformity. Patients with the history of maxillofacial trauma in the preceding 1 year. And patients with head and neck malignancy. Observation and results. Mean age of the study population was 33.92 years. The study included 34 males and 10 females. Number of patients with anterior, posterior, and combined deviation were 15, 10, and 19, respectively. Subjective improvement after surgery. The mean preoperative and postoperative no scale. Today the score is in conventional group were 16.36 and in 4.18 in endoscopic. The mean decline in score was 12.18. In endoscopic group, the average preoperative and postoperative score were 17.0 and 1.23. The average reduction in score was 15.77. Mean time taken for the surgery significantly less for anterior deviation corrected by conventional method, that is 46.42 minutes as compared to the endoscopic method, that is 81.25 minutes. Similarly, for posterior deviation, time taken was significantly more in the conventional group, that is 75 minutes as compared to endoscopic group, which is 60 minutes. In the combined subgroup, time taken for conventional septoplasty and endoscopic septoplasty were 80 minutes and 81.11 minutes respectively. Drop leading to significantly less for the cases having anterior deviation undergoing conventional septoplasty, which is 29.29 ml as compared to those undergoing endoscopic correction, which is 42.50 ml. Average blood loss for posterior deviation in conventional group was 55 ml, while it was 31 ml in endoscopic septoplasty group. in the combined subgroup of mean blood loss recorded in conventional septoplasty group was 67.78 ml, while it was 58 ml per cases in endoscopic group. This is regarding the pain. In our study, patients undergoing endoscopic septoplasty had significantly less post-operative pain. This is regarding the complications. In conventional group, total 4 patients had complications, 2 had Sinus, 1 patient had an infection, and 1 patient had hemorrhage. In endoscopic group, complications were seen in 3 patients, 2 cases of Sinus and 1 of septal perforation. Coming to discussion, deviation of the nasal septum is very common but not always symptomatic. Septal surgery is a treatment for symptomatic deviated nasal septum. Our study aimed at comparing the results of endoscopic septal surgery versus conventional septal surgery using 4 parameters. They are subjective improvement in symptoms 3 months after surgery using validated nose score, intraoperative blood loss, and third one is the post-operative pain, and last one is the incidence of complications. The endoscopic septoplasty was significantly better than the conventional method of surgery. This is probably because the endoscopic technique provides a direct targeted approach to the septal anatomical deformity, allowing a minimally invasive procedure with limited septal mucosal flap dissection and removal of small cartilaginous or bony deformities. An important observation in our study was that surgical time and blood loss during the correction of anterior deviation with endoscopic approach was more, and it was significantly lesser, predominantly posterior deviations. We found that the patient undergoing endoscopic septoplasty had significantly less post-operative pain and complication than the conventional septoplasty. Coming to conclusion, both the conventional and endoscopic septoplasty techniques were found to be very effective in relieving nasal obstructions. The anterior deviation could be corrected significantly faster and with minimal bleeding using the conventional method. The posterior deviations had significantly lesser bleeding and operative time when corrected endoscopically. There is significantly less post-operative pain and complication in endoscopic work as compared to conventional work. Considering the distinct advantage of endoscopic septoplasty over a conventional technique, we strongly suggest that at least the posterior deviations are approached by the endoscopic approach. These are my references. Thank you.
Sir, any questions? Sir? Ramesh sir, are you there? Okay, I call upon next candidate, Dr. P. Uday Bhaskar. Dr. P. Uday Bhaskar.
Yes, sir. I'm sharing the.
Unmute yourself.
Good afternoon, everyone. I'm P. Uday Bhaskar.
Start your case.
Hello. Good afternoon, everyone. Hello. Am I audible?
Yes, you
Hello?
are audible. Please continue.
Good afternoon, everyone. My case series presentation is comparing tracheostomy techniques, jaw flap versus tracheal window. Tracheostomy is a commonly performed surgical procedure that allows the patient to breathe while bypassing the mouth, nose, and the throat. Various techniques have been developed for making the tracheal incision. The tracheal window technique and the jaw flap are the most commonly used. Each has its own benefits depending upon the patient and tracheostomy circumstances. In this study, we offer our institutional experiences with the jaw flap and window tracheostomy patients and how the tracheostomy incision type affects the patient's outcome. Materials and methods. A retrospective study is done considering 30 patients. A method of selection is the simple random sampling. All patients who underwent tracheostomy are included. Duration of study is 18 months. Results: a total number of 30 tracheostomies were evaluated for this study, of which 14 have jaw flaps and 16 has window tracheostomy technique. There was no significant difference observed in the age, gender, or race between the groups. Patient who has higher body mass index have jaw flap tracheostomy. And patient had who has history of a stroke had and also on ventilators have underwent jaw flap technique than window technique. Patient who had a history of connective tissue disease and history of premier neck radiation, premier neck dissection underwent window technique than jaw flap technique. Post-operative outcomes. There was no statistical difference between jaw flap and window regarding post-operative bleeding and days to decannulation or ability to be decannulated. Patients who received jaw flap were found to have statistically higher 30 days mortality in all tracheostomies. Thrombocytopenia was found to be significantly correlated with the post-op bleeding. Discussion: jaw flap tracheostomy. A U-shaped incision was made on the anterior wall of trachea. A flap is reflected anteriorly and sutured to the skin. Jaw flap attached to the skin allows the stroma to be more easily identified than window. Jaw flaps are most commonly used in patients with an anticipated difficult tracheostomy tube replacement. Jaw flaps are most likely performed on patients from the intensive care unit. It is easy to perform bronchoscopy and provide less resistance for the ventilator support. Drawbacks to the jaw flap include a higher rate of bacterial colonization in the stroma and there will be higher chances of the infection. Window tracheostomy. Incision was made in such a way that a circular or rectangular hole is created on the anterior wall of by removing the anterior position of the tracheal ring. The window technique was most likely to be performed in the head and neck cancer patients. Window technique was more likely to have an awake or emergency tracheostomies. Jaw flap likely to have a larger tracheal window, larger tracheal diameter, and lesser tendency towards stenosis than the patients with a window. Jaw flap has also been shown to decrease the rate of tracheal narrowing at the level of stroma than the window. This image showing the jaw flap technique. In this, a U-shaped incision is given and the flap is retracted anteriorly and sutured to the skin. And this image shows the window tracheostomy. Here, a circular reticular hole is created on the anterior wall of trachea. Conclusion: patient with a history of prolonged mechanical ventilation, higher body mass index, and history of a stroke were more likely to have a jaw flap performed during the tracheostomy. Window techniques are more likely to be performed in a head and neck cancer patients. and with a history of prior neck radiation and previous history of head and neck surgeries. As the incidence of complications is low, ranging from 2.1 to 20% depending on the medical center, and often trichostomy patients have increased mortality. A larger sample size will be needed to determine whether one method of entering the trachea is superior to another. So further prospective studies are needed to compare the long-term outcomes of the each of these techniques. These are my references. Thank you.
Okay, sir, I'm finished.
That word tracheostomy is derived from which?
Sir, it is derived from Latin, sir.
It's Greek.
Greek, Hippocrates.
Do you know any modifications of this broach technique?
Yes, sir. So it after opening the skin, the fat is debulged, and the U shape is given, sir, on the second, third, and fourth tracheal rings, and flap is elevated, and it is sutured to the skin, sir. This was the latest technique used.
This is all adult patients.
Yes, sir. In pediatrics, it should not be done, sir.
Yeah.
Because the incision is larger, there is chances of tracheoesophageal chances of injury to the esophagus, sir.
Shall I call the next candidate, sir? Next candidate, B. Sai Sarna.
Sir, good afternoon, sir. Sir, is my screen visible, sir?
Please open your presentation.
Sir, my screen visible, sir?
Yeah, it is visible. Please start your presentation.
Good afternoon, one and all. Today I'm going to present my study on clinicopathological characteristics of sinonasal and nasopharyngeal tumors. Coming to the introduction, nasal cavity and paranasal sinuses are the site of origin for complex and histologically diverse group of tumors in human body. These neoplasms are derived from mucosal epithelium, seromucinous glands, bone, cartilage, neuroectodermal tissue, and hematolymphoid cells. They present with features like epistaxis, nasal obstruction, and nasal discharge. These contribute to about 0.2 to 0.8% of all the malignant neoplasms and 3% of head and neck malignancies. Out of these tumors, 60% originate in maxillary sinus, 20 to 30% in nasal cavity, 10 to 15% in ethmoid, and remaining 1% in sphenoid and frontal sinuses. Higher incidence has been noted in Japan and some parts of China and India. The aim is to study the clinicopathological characteristics of sinonasal and nasopharyngeal tumors. The objectives are to study the clinical and histopathological presentation of these tumors and to know the role of immunohistological markers in the diagnosis of these tumors, and also to study the management of these sinonasal and nasopharyngeal tumors. I have conducted a study on 18 subjects for a period of 6 months from January 2022 to June 2022. Consent was taken from all the patients, thorough history, clinical examination was done, diagnostic nasal endoscopy, CT-PNS, MRI-PNS was done, immunohistochemistry was done for malignant cases, and after all the investigations, diagnosis, appropriate medical and surgical treatment was given to the patients and followed up for 3 to 6 months. The inclusion criteria of my study were the subjects who had nasal mass on anterior rhinoscopy and diagnostic nasal endoscopy, and also those who had nasal mass on CT scan and MRI scan. Exclusion criteria were the subjects who had adenoid hypertrophy on diagnostic nasal endoscopy. Here I would like to discuss a few rare cases which we have overcome in our institute. A 80-year female complaining of right-sided nasal obstruction and nasal bleed with right cheek swelling with CTPNS was found to have sinusitis in the right paranasal sinuses likely to be invasive fungal or neoplastic etiology. Contrast MRI was done, which shows an hyperintense lesion seen in the right paranasal sinuses with intracranial extension and caudal extension to the roof of oral cavity. Biopsy was taken, which shows areas of necrosis with hemorrhage and no features of malignancy were seen, and hence we went forward with surgery of FES and debridement of the nasal mass was done to relieve the patient from its symptoms. That specimen was suggestive of moderately differentiated squamous cell carcinoma. The next case, a 45-year female, agriculture by occupation, complaining of left-sided nasal obstruction with watery nasal discharge associated with nasal bleed. She also had left eye blurring of vision. On DNA, there was a polypoidal mass in the left nasal cavity which was insensitive to touch and was bleeding on touch. CTPNS was suggestive of ill-defined heterogeneous enhancing mass involving the left paranasal sinuses with intracranial extension. Debulking of that mass was done with cobblator and debrider. HPE was suggestive of poorly differentiated carcinoma. Further, immunohistochemistry was done, which was positive for pancytokeratin, chromogranin, and synaptophysin, hence suggestive of small cell neuroendocrine carcinoma. On the follow-up of the patient, she had recurrence of the tumor again at 3 months. The next one is pituitary adenoma, a 25-year male complaining of bilateral nasal obstruction and nasal bleed since 2 months. On examination, patient had bilateral proptosis of eyes with lateral restriction of the movements. On DNA, there was a pinkish mass present in the left nasal cavity, insensitive to touch and was bleeding on touch. Probe was not able to pass superiorly. On EUM, you can also see there was a bulge in the posterior inferior quadrant in the tympanic membrane. On VLS, there was a bulge noted in the posterior pharyngeal wall. On contrast MRI, there was an heterogeneously enhancing lesion which was involving the entire skull base, and anteriorly it was extending up till the nasal cavity. Superiorly involves the sella suprasellar region obscuring the pituitary optic chiasma. DNA and biopsy were done, which was suggestive of small round cell tumor. On further immunohistochemistry was positive for synaptophysin and CD56. CD99 was diffusely positive in some lesional cells, and negative for chromogranin, ACTH, calretinine, NKX 2.2, and was suggestive of pituitary adenoma. Patient was advised radiotherapy. Next case of 55-year-old male complaining of left side nasal obstruction and left eye swelling, and there was no history of any wood dust exposure. On DNA, there was a mass in the left nasal cavity which was insensitive to touch and bleeds on touch. On MRI, there was a mass predominantly on the left side which was eroding laterally the lamina preparatia, superiorly the ethmoid root. Inferiorly, it was eroding the hard palate, but there was no intraoral extension. Biopsy was taken from that nasal mass, which shows inflammatory infiltrates, and no etiology of malignancy was seen. Hence, we thought it was mostly of invasive fungal etiology, and we did debridement of that nasal mass, and the intraop CSF leak was closed with opposite side middle turbinate. That specimen came out to be sinonasal intestinal type adenocarcinoma. On immunohistochemistry, it was CBX2 and CK20 positive. CK7 was variable positivity. On the follow-up of the patient for 6 months, there was no recurrence of the tumor observed. Next patient of 60 years male complaining of right side cheek swelling and right eye vision loss. On DNA, there was a pinkish mass noted in the nasal cavity which was insensitive to touch and was not bleeding on touch. MRI showed skull base tumor, that lesion extending to right middle cranial fossa and was eroding the clivus, greater wing of sphenoid, and was also extending till right superior and inferior orbital fissures. DNA and biopsy was done, which was suggestive of moderately differentiated chondrosarcoma. Patient was advised radiotherapy but did not underwent. Of my study, the results were out of the 18 cases which I have studied, 11 were benign and 7 were found to be malignant. And mostly there were 4 cases of hemangioma followed by fibrous dysplasia, angiofibroma, carcinoma of nasopharynx, and each case of the above discussed cases like squamous carcinoma, adenocarcinoma.
1 minute left.
Okay. Sex distribution was more in males of 1.25:1. Age in the benign tumors was more towards adolescence age, whereas for malignant, it was more in 60 and above. And nasal symptoms were presented with nasal obstruction being the most common one and anosmia being the least. Treatment modalities were surgery was done for benign lesions, whereas surgery radiotherapy was given for malignant, and in some malignant cases only radiotherapy was given. Discussion: tumors of this cyanonasal cavity are rare with incidence of 0.5 to 1 in 1 lakh. Wood dust exposure is the common risk factor. CT and MRI has to be done to know the extent of the tumor. It can involve orbit, and also laterally it can involve pterygopalatine fossa, infratemporal fossas, and from sphenoid it can involve cavernous sinuses. I would like to conclude by saying that biopsy and histopathological examination is the gold standard for diagnosis of these tumors, and immunohistochemistry will provide us a tool for substantiating
Dr.
this
Swarna, your
diagnosis.
time is up.
Yes, thank you, sir.
The next candidate, Sri Lakshmi Soumya.
Good afternoon.
Dr. Sri Lakshmi Soumya.
Good afternoon, sir. Sir, is my screen visible, sir?
Share your screen.
Sir, is my screen visible, sir?
Yeah. Start your presentation.
Good afternoon. Today I am going to present a case series on non-vestibular schwannomas in ENT. Schwannomas are benign, well-encapsulated, slow-growing nerve sheath tumors composed exclusively of Schwann cells. These tumors can originate from any myelinated central or peripheral nerve cells. Their clinical presentation vary depending on their different sites of presentations. MRI is the most preferred mode of diagnosis, whereas the confirmation for diagnosis is always the post-operative histopathological examination. The most accepted treatment for schwannoma is surgical resection. Today, my aim is to report 9 cases of schwannomas in ear, nose, throat, and neck other than vestibular schwannomas. Now we'll start with first case of a 21-year-old male who came to OPD with complaint of a mass in right external auditory canal since 1 year. He had no other complaints related to ear. On examination, we found a single pinkish polypodal mass of 1 mm in right external auditory canal. There were the rest of the ear findings were normal. This mass was excised in toto and base was cauterized and sent for histopathological examination, which showed to be as a schwannoma. Case was followed up for 3 months and he showed no recurrence. There is another case of a 21-year-old male who came with complaints of swelling in front of the left ear since 3 months, which was gradually progressive in size. On examination, a single firm non-tender swelling of about 2 by 2 centimeter is seen anterior to right tragus with no sinus or discharge from the swelling. Finally, aspiration cytology suggested it to be either a pleomorphic adenoma or a first Frankel cleft cyst. So we went forward with the excision of tumor under general anesthesia and sent this tumor for histopathological examination, which showed it to be a schwannoma. Case was followed up for at least 3 months and it showed no recurrence. A 45-year-old male now presented to our OPD with complaining of left cheek swelling since 10 months and progressive left nasal obstruction since 10 months. On examination, a single firm non-tender swelling of about 6 by 4 centimeters is seen over his left maxillary region. Skin of the swelling was normal and diagnostic nasal endoscopy showed a single pinkish smooth globular mass in left nasal cavity. This was not sensitive to touch or not bleeding to touch. Now we went forward with the diagnostic nasal endoscopic guided biopsy, and this report suggested a schwannoma. Then we did imaging with computerized tomography of paranasal sinuses, which showed soft tissue density in left maxillary sinus with the thinning of all the walls. Then this case was managed with infrastructure maxillectomy by Weber fugers and incision under general anesthesia, and mass was again sent for histopathological examination, where the diagnosis was reconfirmed to be schwannoma, and it's a cellular type of schwannoma. There is another case of a 48-year-old male who is with a paranasal sinus schwannoma. He came with complaint of swelling in the right cheek since 6 months, but he did not have any nasal obstruction or any complaints. Neither we found a mass on anterrhinoscopy or diagnostic nasal endoscopy. This patient scan was done and maxillary sinus showed a mass which was eroding into all the walls and also into the inferior orbital wall. This patient underwent right middle meatal antrostomy with biopsy from the tumor, and this was subjected to histopathological examination, which showed it to be a schwannoma. This is another 40-year-old male with a complaint of nasal obstruction since 6 months, and diagnostic nasal endoscopy showed a single pale globular mass in right nasal cavity. This patient was managed with endoscopic excision of tumor and was sent for histopathological examination, which showed out to be schwannoma. Patient was followed up for 6 months and there was no recurrence. Now, there is a 50-year-old male who came with complaint of difficulty in breathing since 3 months and gradual progressive change in voice, which is not associated with difficulty in swallowing. On examination, there is a well-defined smooth bulge in the left lateral wall of pharynx, extending into tonsillar fossa, pushing soft palate to the contralateral side. This entire mass was excised in toto through transoral approach and was sent for histopathological examination, and this came out to be a schwannoma. Another lady with a swelling in the left parapharyngeal abscess presented to us at 53-year-old age with complaint of pain in throat since 2 months. This case was we tried to do a ultrasound guided fine needle aspiration preoperatively, which could not give much information other than a hemorrhagic aspirates. Now, so we went forward with the transcervical approach, and mass was excited in toto and was sent for histopathological examination, which was consistent with schwannoma cellular type. Case was followed up for 8 months and there is no recurrence. Now, there is an interesting case of 24-year-old female who presented with swelling over the right side of the neck since 4 years, which is gradually progressive and not associated with pain or fever. Before visiting our hospital, this particular patient has underwent fine needle aspiration cytology twice, which suggested of granulomatous lymphadenitis, and Cox couldn't be ruled out. Based on this report, patient has underwent anti-tubercular therapy twice, once for 6 months therapy and once for a 9 month therapy. Later, when she approached us, we repeated our fine needle aspiration, which showed some epithelial cells with elongated nuclei with microfollicular arrangement. So this was probably suggesting of an aberrant thyroid and cervical lymph node. So we went forward with the excision of the mass and subjected to histopathological examination, where we got the confirmatory diagnosis of schwannoma. Here is a 13-year-old female with complaint of swelling over the tongue since 1 year. This was a firm swelling which we excised in toto and sent for histopathological examination, and there it was confirmed to be a schwannoma. With this, I finished my 9 cases. Schwannoma is the most common nerve sheath tumor. 60% of benign schwannomas are vestibular schwannomas. Only 25 to 45% of schwannomas are possible to occur in the extracranial head and neck region. My case series consists of exclusively such 9 cases. Cyanonasal schwannomas represent less than 4% of the schwannomas. This study includes 3 of such cases. And intraorally schwannoma occurrence vary widely between 1 to 12%, and we include 3 cases of schwannoma which present intraorally, tongue being the most common site of presentation. The most common age of presentation is 50 to 60 years, but this study includes patients from a wide range of age gap from 13 years to 58 years. Histologically, there are 4 types of schwannomas: classic schwannoma, cellular schwannoma, plexiform schwannoma, and melanotic schwannoma. In my study, 7 out of 9 patients were of classic variant, whereas 2 patients came out with cellular schwannomas. With this study, I want to conclude that we should all keep schwannoma as an important differential diagnosis for any benign tumor. It is not so uncommon to occur in the field of otorhinolaryngology, head and neck. This can occur in any site in any age group of patients. And preoperative radiological and histological proper evaluation of a tumor is very important. Complete resection can prevent the cause of recurrences, and postoperative histopathological examination is must for any growth to get the complete diagnosis and also to know the epidemiology of the disease for future. These are my references. Thank you.
What is the gold standard in this treatments of the schwannomas?
Sir?
Surgical aspect. What is the gold standard?
Sir, surgical resection, sir. Or
What's the gold standard where you have to remember? What is that?
We have to see that the nerve sheath is, without damaging the nerve, we should try to excise
the tumor root is protected. What is the take-home message from your research?
Sir, before going forward with any surgery of any tumor, we must remember there is something called schwannoma, so that this can be in proximity with the nerves. So I feel it is better to preoperatively evaluate in more vigorous way rather than just going surgeries to prevent any complications for the nearby nerves, sir.
Yeah, what is the incidence of recurrence in the schwannoma?
Recurrence is very rare, sir, in schwannoma.
How rare it is? Like, have you followed up? How long to be followed up? Any follow-up protocol?
No, sir. No. Studies telling recurrence is very rare, sir. With complete resection, there is no case of recurrence of schwannomas.
Okay. Thank you.
Next presentation by Dr. P. Durga. Dr. P. Durga.
Yes, sir. Good afternoon, sir. A study on role of nose scale in the management of allergic rhinitis. Introduction. Allergic rhinitis is an inflammatory airway disease in which the production of inflammatory mediators and inflammatory cell infiltration are prominent, with the clinical manifestations of sneezing, nasal congestion, nasal itching, nasal blockage, and rhinorrhea for 2 or more consecutive days for more than 1 hour on most of the days. Allergic rhinitis is a global health problem and the patient present with varied symptoms. Nasal obstruction symptoms evaluation scale is an outcome instrument used in multi-center observational clinical study. Absolute eosinophilic count is an easy, simple, non-invasive, reliable test, valuable and very economical. In this study, we have correlated the nose scale and the absolute eosinophilic count and the efficacy of steroid nasal spray based nose scale in allergic rhinitis. The aim of the study is to assess the role of nose scale in the management of allergic rhinitis. Coming to materials and methods, it's a prospective observational study and the subject selection is from the ENT outpatient department where the study period is for 12 months and the sample size is 140. Inclusion criteria, patient having symptoms of allergic rhinitis were included like sneezing, nasal pruritus, rhinorrhea, nasal congestion, eye watering and pharyngeal itching. Exclusion criteria include smokers, pregnant women, chronic persistent severe asthma, chronic respiratory illness like bronchiectasis, pulmonary tuberculosis and other obstructive airway diseases, recent nasal surgery or any anatomic defects of the nose, and the recent 2 courses of parenteral steroids within 3 months of screening and the presence of any comorbid systemic illness and the use of oral or nasal decongestant 1 week prior to the treatment. The methodology includes a clinical examination of ear, nose and throat were done in all the cases and the common signs of allergic rhinitis are observed and the subjects were reassessed after 3 months of use of steroid nasal spray and the nose scale was taken, which was compared with the nose scale before steroid nasal spray was instituted. Observation and the results. Nasal obstruction symptoms evaluation scale was given to all the subjects who enrolled for this study. Absolute eosinophilic count was taken before starting steroid nasal spray. Normal absolute eosinophilic count is more than 440. And the nose 1 scale was taken before starting the steroid nasal spray and it was correlated with the absolute eosinophilic count. Nose 2 scale was taken after the use of steroid nasal spray for 3 months and followed up and correlated with the nose 1 scale. These are the symptoms which are included in the nose scale and they are graded according to not a problem, very mild problem, moderate problem, fairly a bad problem and severely problematic. And the symptoms include the nasal stuffiness, nasal obstruction and the trouble in breathing through the nose and trouble during sleep and the trouble during any exercise. And the comparison of between the nose 1 and nose 2 scale. The utility of nose 1 scale in predicting the absolute eosinophilic count abnormality was assessed by receiver operative curve analysis. Area under the receiver operative curve along with the 95% of class interval and the p-value are presented. With the p-value less than 0.05 was considered as statistically significant. Out of 140 patients, 126 patients has the abnormal absolute eosinophilic count and the 14 patients in the study population has a normal absolute eosinophilic count values. This is a correlation between the nose 1 scale and the absolute eosinophilic count with the p whose p-value is less than 0.001. Coming to the discussion, allergic rhinitis development depends upon the interaction between the genes, environment, and immunological factors. To date, tests for rhinitis have no sensitivity and specificity, and therefore diagnosis is mainly based on the clinical history. Association between the eosinophils and the allergic disease has been published in various studies. In our study, the mean absolute eosinophilic count was 633.07 plus or minus 152.77 in the study population, with the minimum level of absolute eosinophilic count was 440 and the maximum level was 900 in the study population.
16.
In our study, NOS1 scale had excellent predictive validity in predicting the absolute eosinophilic count in allergic rhinitis. There was a strong positive correlation between the NOS1 scale and absolute eosinophilic count in the study population, indicating both the variables are interrelated and indicating the severity of symptoms of allergic rhinitis. In our study, NOS1 scale was correlated with absolute eosinophilic count and it was statistically significant.
16.
14. On using the intranasal steroid spray, comparing NOS1 and NOS2 scale, it was found out that there is improvement in symptoms and reduced NOS2 scale. Absolute eosinophilic count was not done after the use of intranasal steroid spray, as subjects were symptomatically better. Intranasal corticosteroids improved symptoms of allergic rhinitis, particularly nasal obstruction, leading to lower NOS scale. Coming to conclusion, NOS scale evaluation.
Yeah, you can go ahead.
Coming to conclusion, NOS scale evaluation is simple, economical, and non-invasive. Hence, it can be used in the management of allergic rhinitis in a clinical setup. In this study, the correlation between the intranasal steroid spray and NOS scale has been done. These are my references. Thank you, sir.
How could you improvise your study? You have only followed the nose scale. Any other you could have included to improvise your study?
Sir, along with NOS scale, comparison with the absolute eosinophilic count, sir, before starting the steroid nasal spray and after steroid spray, sir.
What is sonoelastography?
Sonoelastography, that is wave pattern, sir.
Okay.
Non-invasive method of measuring the elasticity and sensitivity, sir, of the nasal mucosa.
Next presentation by Krishna Priya. Dr. Krishna Priya.
Manoj and
Yes, sir.
Sriharsha.
Yes, sir.
Sriharsha is there. Okay. I request all the participants kindly mute while the presenter is presenting the paper. So there are a lot of noise, the background noise is there. So don't disturb others. Thank you. Thank you. Go ahead.
Next presentation by Dr. Krishna Priya. Dr. Krishna Priya.
Six, huh?
Please.
Okay.
35.
35.
41.
41.
43.
33.
43. 9.
Huh?
49.
49.
51.
31.
44. 46.
46.
31.
31.
41. 21.
21.
Dr. Krishna Priya, please show your PPT.
Hey, that is Peru Vishnu Prasad.
Manoj, if she is not there, call a next candidate. And once again I request others, please mute. Sriharsha, are you there?
Next presentation by Fatima. Next presentation by Dr. Fatima.
Yeah.
36.
36.
44.
44.
Hello, sir. Thank you. Sir, am I audible?
Yes, you are audible.
On your video, Fatima.
Yes, sir. Opening, sir. Sir, am I visible, sir?
Yes, you are audible.
Yes, sir. Good evening, sir. Today I am going to speak about rhinosporidiasis and nasal cavity case series. Introduction. Rhinosporidiasis is a chronic granulomatosis disease of the mucous membrane of predominantly nose caused by Rhinosporidium sebri, which is an aquatic protozoan found in mostly in stagnant water. Characterized patients mostly come with the history of rhinorrhea, chronic epistaxis, and progressive nasal obstruction. The disease is characterized by the formulation of papillomatous or polypoidal and friable mass. The diagnosis is mainly based on clinical examination and histopathological examination, as the organism is non-cultivable. The only curative approach is surgical excision with electrocoagulation of the base. Here I report 5 unusual cases in migrate as well as resident population of Hyderabad with a view of rhinosporidiasis revisited. My aims are to study the incidence of disease in non-endemic areas and to highlight the need for awareness among clinicians in non-endemic regions and consider it as differential diagnosis in patients coming with similar complaints. A total of 5 patients with clinical diagnosis of rhinosporidiasis were monitored pre-op, intra-op, and were followed with CT scan and SHP. All the patients attending OPD with history of epistaxis were included. My case 1. A 30-year-old male patient from Orissa, laborer by profession, resident of Hyderabad, since 1 year, presented to OPD with history of right nasal obstruction, headache, and nasal discharge of 8 years duration. He has been misdiagnosed as nasal polyp 6 years back and 2 years back and was operated for it in the government hospital at Orissa. Histopathological examination at that time was not done. There was a history of bathing in ponds. Normal general and physical examinations was normal. An examination anti-rhinoscopy revealed right nasal cavity completely obstructed by friable mass. Left nasal cavity was partially obstructed due to the mass. CECT revealed soft tissue in the right nasal cavity extending up to the nasopharynx, partially obstructing on the left side. His CDP and other investigations were normal. He was taken for endoscopic excision from the right nasal cavity. The endoscopic excision was done and he was given post-op dapsone therapy for at least 3 months. The mass was sent for histopathology, which suggested thick-walled sporangia with numerous endospores, which was suggestive of rhinosporidiasis. On follow-up for 6 months, there was no recurrence. Case 2 is a case of 45-year-old patient with a resident of Hyderabad presented to OPD with complaints of right nasal obstruction and mass in the oral cavity 6-month duration. No history of similar complaints in the past. No history of bathing in the ponds. His general physical and systemic examinations were normal. An examination with rhinoscopy, septum was seen in midline, nasal mucosa was congested, oral cavity showed mass in the oropharynx. When endoscopy was performed, it showed pinkish proliferative mass studded with whitish dot was seen occupying the right nasal cavity, extending from the inferior turbinate up to crura. CT confirmed the findings. His blood count and other parameters were normal. He was again taken for endoscopic excision of the mass with cauterization of base. The mass was delivered from oral cavity under general anesthesia and was sent for histopathological examination, which was suggestive of rhinosporidiasis. On follow-up, there was no recurrence. The case 3 is a case of 55-year-old male patient, laborer by profession from Hyderabad, presented with a nasal mass of the right nostril for 1 year. He complained of nasal obstruction for 2 months, history of intermittent epistaxis. Since 1 year, for which he was treated with local remedies. There was no history of bathing in stagnant water. On examination, anterior rhinoscopy revealed a friable vascular papillomatous mass with whitish spot. Oral examination and left nasal examination was normal. General examination revealed mild pallor. Rest systemic examination was normal. The patient was taken for excision of the entire mass with cauterization of the base. The mass was again sent for HP, which was suggestive of rhinosporidiasis. Patient was followed for 1 year with no recurrence after that time. Here is a case of 29-year-old male, farmer by occupation, presented with chief complaints of left nasal mass and left nasal obstruction for 6 years. History of bleeding was present, intermittent. Without history of bathing in the ponds, there was no history of similar complaints in the past, no history of previous surgeries or any significant past history. On examination, a red-colored pedunculated mass was seen in the left nasal cavity with surface studded with white to yellowish dots. CT confirmed the findings and patient was taken for endoscopic guided bite excision of mass with cauterization of base, and the specimen was sent for histopathological examination, which showed several sporangia round to oval at different stages filled with endospores suggestive of rhinosporidiasis. Case 5 is a case of 53-year-old patient, resident of Hyderabad, came to OP clinic with history of mass in the right nostril for 2 years and swelling below the right eye for 1 year. Patient was not diabetic and not any medication before coming to hospital. There was no history of baths in the pond. Patient complained of anosmia, nasal obstruction, no complaint of epistaxis, nasal discharge, or headache. On local examination, a mulberry-shaped mass was seen protruding out of the right nasal cavity, not bleeding on touch. Oral cavity examination was normal. CT scan showed pan-sinusitis and ethmoidal polyp. Surgery, he underwent complete endoscopic excision of the mass after bipolar cauterization of the base. The multiple sporangia in various stages were found, suggesting rhinosporidiosis. So my results mostly include the age of patients between 30 to 50 years, and 2 of my patients were from endemic areas and 3 of them were from Hyderabad. 2 of them had history of exposure, and all were uniformly treated with surgical excision followed by dapsone therapy. Until now, no recurrences seen. Since all the patients were treated uniformly, same gender and same age, there was no statistical differences could not be made. Discussion and review. This study documents and reports the incidence of nasal rhinosporidiasis in non-endemic regions of Hyderabad. Rhinosporidiasis, Sporidium sebri, though now related to a group of fish parasite, most microbiologists initially considered it as a fungus based on its property to be stained by fungal stains such as Giemsa and periodic acid shift. A study done by Silva et al. Using phylogenetic analysis transcribe sequences raises the possibility that the genus Rhinosporidium may possess multiple host-specific strains and indicates that it recovered from humans. Could have diverged according to its geographical location. Recent studies provide evidence that its natural habitat is water and perhaps soil contaminated by waste. The route of transmission is unclear, although most common transmission is trans-epithelial through traumatized epithelium. Other includes auto-inoculation through spillage of endospores by trauma or during surgery, hematogenous lymphatic infection. The disease is prevalent mostly in rural settings, particularly among individuals working in contaminated soil and stagnant water or sand. In our cases, 2 patients gave a history of contact with contaminated pond. Contact with feces or infected livestock or water flow and even working in contaminated agriculture field has also been reported as risk factor. As the disease has slow course, regions may present for years before the patient becomes symptomatic, which was true in our cases. Suggested that the results of dapsone were not convincing, as these were inaffected and followed by recurrences. Another study conducted showed that it is effective and safe drug in a clinical trial with low rate of recurrence and follow-up, but in our case, we successfully treated the patient post-op with dapsone without recurrence. A study conducted by Shailesh educated dissemination of disease, which was fatal. However, this dissemination is very rare and not reported in our cases. My conclusion is, though it is uncommon, it should be kept as differential diagnosis while treating any nasal mass, and biopsy should be taken whenever possible. Surgical excision with bipolar coagulation is the treatment of choice. Recurrence is less common if complete removal is done. The only drug appearing to have clinical promise now is dapsone. These are my references. Thank you.
Next presentation by Dr.
How does
Krishna.
Hello, sir. Sorry to interrupt, sir. I'm Krishna Priya, sir. Hello, sir.
Next presentation by Dr. Krishna Priya.
Thank you, sir. Hello, sir.
Udusia, stop sharing your slides. Stop sharing your slides.
Krishna Priya, please share your slides.
Yes, sir. Second presentation. Yes, sir.
Timer.
Yes, sir. Yes, sir. Yes, sir. Am I visible, sir?
Please share your slide.
I'm sharing the slide, sir. Am I visible, sir?
Yes, you are visible. Please start.
Yes, sir. Good afternoon, everyone. I'll be presenting a case series on the topic is polycythoma aggressive in this antibiotic era. Introduction. Chronic subcutaneous otitis media is defined as chronic inflammation of the middle layer and vascular cavity. It's present with recurrent ear discharge plus tympanic membrane perforation. Clinical presentation of chronic otitis media varies in underlying severity of infection or response in the time course of infection. Scale for the polycythoma is typically a persistent disease. Chronic inflammation caused by recurrent infections is one of the contributing factors to pathology. Polycythoma can cause destruction of the structures in the middle atlas, which is locally invasive nature. Chronic infections can the effects of polycythoma. The most frequently identified bacteria in polycythoma are Pseudomonas, Staphylococcus, and Proteus. One of the problems we are facing today is indiscriminate use of antibiotics, which lead to marked or latent infections with increasing complication and evolving resistance patterns. Hence, frequent use of topical antibiotics as empirical treatment for each instance of CSI must be reconsidered, and antibiotics should be used in caution. With the introduction of new generation antibiotics and its effective use during post-op periods following MRM, the bacteriology of oral and intra polycythoma swab is of relevance for achieving dry vascular cavity. It is important to detect the bacteria and start with appropriate sensitive antibiotics to prevent persistent infection that can delay healing. Aims and objective of the study is to correlate the intraoperative findings of polycythoma in preoperatively managed with antibiotics and to compare the incidence and the extent of complications with polycythoma. A total of 50 patients with chronic otitis media Squamosal type with clinical diagnosis of polycythoma and plan for mastectomy are monitored preoperatively and intraoperatively and invested with the following: oral swab, intraoperative polycythoma swab, and intraoperative findings of extended polycythoma. Inclusion criteria are all patients treated in ENT locally with CSI of Squamosal type, whereas the exclusion criteria is patient with CSI of mucosal type, patient with ear discharge of other causes such as otitis externa or automycosis, patient with diabetes and other immunocompromising conditions, patient not willing for research and not fit for surgery. Collection of specimen, the oral swab is collected under good elimination from the EAC with a clean, dry, sterile swab. And polycythoma matrix during master surgery, the polycythoma matrix is exposed and collected in sterile glass tube and transferred in a normal sand for bacteriological study. The microbiological study is conducted after incubation at 37 degrees Celsius for 24 hours, and microorganisms identified using standard bacteriological techniques. Antibiotic sensitivity testing is done for preoperatively for oral swabs, and appropriate antibiotic therapy is started. Polycythoma matrix specimens were processed in a similar way and sensitivity pattern was determined. This diffusion method is used for the following procedure. My result is total of 50 patients were studied, out of which 28 were male and 22 were females. Mean age was 26.96 years. Out of 50 cases, microorganisms were isolated from oral swabs of 38 patients, whereas 12 patients had sterile oral swabs. 33 patients had positive polycythoma culture reports and 17 had negative culture report. Most common organism isolated from oral swab was Staph aureus, followed by Proteus, and from polycythoma culture it was Staph aureus and Pseudomonas. Enterococcus and Acinetobacter were mostly isolated from polycythoma culture and were amply with oral swabs. The microbiological picture showing Staph aureus and Pseudomonas aeruginosa. From my study, I got 9 cases who showed same organism for oral swab and polycythoma culture, whereas 17 cases showed different organisms. Oral swab negative and polycythoma culture positive were seen in 7 cases, whereas oral swab positive and polycythoma culture negative in 12 cases. 5 cases showed sterile culture in both the cases. Intraoperative findings. Out of 50 cases, 33 patients underwent canal down mastectomy and 27 underwent inside canal mastectomy. Foliar notions with aggressive polycythoma were noted in 23 of the patients. Most common intraoperative findings among them was ocular erosion, which composed of 20%, out of which 12 patients showed complete erosion. From my study, I noted segment dehiscence in 2 cases, posterior canal wall dehiscence in 3 cases, ocular erosion in 10 cases, out of which 6 cases showed complete erosion, facial canal dehiscence in 4 cases, intracranial extension in 1, and labyrinthine fistula in 3 cases. Given the intraoperative findings of segment erosion and facial canal dehiscence, the radiological finding of segment erosion on the left side and bilateral sigmoid plate dehiscence. Discussion. The normal medulla microbiome is found to be altered in phase patients by active inflammation. The preoperative oral swab culture, Staph aureus infection was the most predominant among gram-positive bacteria and Pseudomonas among gram-negative bacteria. 72% of the patients with possibly preoperative oral swab culture, remaining 28% can be attributed to prior antibiotic therapy. Preoperative oral swab was collected and antibiotic sensitivity testing done, according to which appropriate treatment was given. Intraoperatively, the polycythoma swab culture turned out to be positive in 66% patients, suggested infectious etiology in polycythoma cases. 14% cases showed positive polycythoma culture despite negative oral swab culture, suggesting that preoperative culture negativity cannot rule out infectious etiology. Colonization by bacteria can lead to biofilm formation in the medulla, which can lead to impaired clearance and consequently chronic medullary inflammation, thus causing persistence of pathogen and establishment of polycythoma. This explains the close relationship between aggressiveness of polycythoma and repeated bacterial superinfection. Hence, it is important to know the bacteria involved in order to control the recurrence following surgery to reduce aggressive potential of the polycythoma and limit the incidence of complication. Most common organisms isolated from polycythoma were Staph aureus and Pseudomonas. Organisms were found to be less vulnerable to commonly used medications like ciprofloxacin and cephalosporins. Also, the resistance pattern among microorganisms is always evolving. Modern concepts of management of chronic suppurative otitis media demands careful assessment of clinical presentation, exchange of destructive process, functional loss, and natural microbial flora within the ear and the sensitivity pattern. My conclusion is that despite appropriate preoperative antibiotic therapy, polycythoma tends to be aggressive. The knowledge of pathogens and the sensitivity in oral swab and polycythoma will help in choosing the appropriate antibiotics during post-op period. Intraoperative swab of polycythoma and the respective sensitive antibiotic therapy is to be followed post-operatively for eradication of disease, improving post-operative outcome, and for decreasing the chances of recurrence, eventually leading to a healthy year. Thank you.
Next presentation by Dr. Lakshmi. Dr. Lakshmi. Next presentation by Dr. Lakshmi.
I'm sharing, sir.
Okay, I can't stop sharing. Yeah.
Dr. Lakshmi, please share your
Yes,
slide.
sir. So is it visible, sir?
No, it's not visible. Next presentation by Dr. Amrut.
Good afternoon, sir.
Dr. Amrut, please
Good
share your
afternoon, sir.
slide.
Okay, sir. Good afternoon, sir.
Yes, you can start the presentation.
Sir, am I visible, sir?
Yes, you are visible.
Good afternoon, sir. My topic is microbiological study of otitis externa, sir. coming to otitis externa, basically it is a condition of the skin of the external aortic canal characterized by edema, erythema associated with itchy discomfort, sir. And it is a typically inflammatory condition, and it is also a most common condition. And predisposing factors include anatomical obstruction of external aortic canal and external aortic canal, which includes stenosis, exostosis, and impacted cerumen. And it also includes hearing aid and earplugs. Otitis externa occurs because mainly the protective lipid and acid balance in the ear is lost. Basically, EAC contains cerumen. It is a wax. It is a hydrophobic. If it is lost, external aortic canal skin is directly visible. If any abrasions occur, if water enters into the external aortic canal, infection may occur. And most common pathogens causing are bacterial and fungal and viral. Bacterial are Staphylococcus and Pseudomonas. And fungal infections are Candida and Aspergillus. Sir. My aim and objectives of the study are to study various types of otitis externa and determine the causative agents of otitis externa and antimicrobial susceptibility pattern of the bacterial isolates. And materials and methods. This is a prospective study carried out in the ENT department during the period of March and July. These are summer and relative humidity is high. So I have carried out this study in this time period. There were total 30 patients were included in the study. Inclusion criteria. Patients who come to the ENT department with severe itching in the ear, pain in the ear, sensation of sound in the ear, and impaired hearing and discharge from the ear were included in this study. Exclusion criteria. We asked the patient who underwent previous surgeries, they were excluded. And automycosis, if any fungal infections in the body, they were excluded in the study, and suspected malignancies and infiltrating tumors. These are the various types of otitis externa, sir. Diffuse otitis externa, chronic otitis externa, and localized, it is furunculosis, and fungal infection, automycosis, Aspergillus niger. And methods of collection of data. Each patient were subjected to detailed history taking and examination. The examination of the auricle and external aortic canal of the patients were done with otoscope, and 3 samples were collected from the affected ear by the examination of the auricle and external aortic canal using bull's eye lamp. And these are my results, sir. Patients who come with to the ENT department, most of them complain pain as the main symptom, and ear discharge as the next symptom, followed by itching and blockade. And we have taken swabs, so we have sent them culture sensitivity. Most of them were fungal infection. KH positive was 50, and the KH and gram positive was 23.3. KH negative and gram positive was 20. KH and gram negative were 26.6%. And various fungal isolates were studied. Among them, Aspergillus niger is the most common, which include 47.6. Next is Candida, and next is Aspergillus flavus and fumigatus. Among bacterial isolates, Staph aureus is the most common, which causes otitis externa. Next is Pseudomonas. Next is Coagulase negative Staphylococcus and Klebsiella. This is the antibiotic sensitivity among bacterial isolates in the study group. Most of them were sensitive to the cephalosporins and fluoroquinolones. These are higher antibiotics which are given only for resistant cases. Amoxiclav was sensitive to Staph aureus and Coagulase negative Staphylococcus. And discussion in the present study, 30 clinical cases of otitis externa were studied in the ENT department, where they were complaining of symptoms like itching, ear pain, and blockade tinnitus. And itching is the predominant symptom only in the earliest stage. Later, pain is the most common symptom. And in our study, KH mount and gram stain smears were subjected to direct microscopy, and most of them reveal fungal elements in 73% of the sample, and gram positive revealed only in 43% samples. In the fungal infection, 53.3% cases were only fungal infection, 26.3 were only bacterial, 16.6 were mixed. Among Among otomycosis cases, Aspergillus niger is the most common fungus isolated. Aspergillus flavus, followed by first is Aspergillus niger, followed by Candida, followed by Aspergillus flavus. In bacterial isolates, Staphylococcus aureus is the most common, followed by Pseudomonas. Conclusion: what I conclude with this study is even though fungal infections are secondary to bacterial infections, our study reveals that fungal infections are more common in otitis externa. As previous slides show that 53% were only fungal isolates, more than bacterial. And these are my references, sir. Thank you, sir.
Next presentation by Dr. Lakshmi. Next presentation by Dr. Lakshmi. Dr. Lakshmi, please share your PPT.
So, sharing, sir.
Dr. Lakshmi, please share your
Yes, I'm
PPT.
sharing, sir. Is it visible, sir?
It's visible.
Yes, sir. Good afternoon, all. Presentation is clinico-audiological evaluation in adenotonsillar hypertrophy. Adenotonsillar disease is a common pediatric ENT disorder worldwide, and the tonsils are the lymphoepithelial tissues located at the entrance of the upper aerodigestive tract, which is the common cause for childhood morbidity. The etiology is usually the recurrent rhinitis, rhinosinusitis, a chronic tonsillitis, and allergy of the upper respiratory tract may also contribute to the enlarged adenoids. The pathological effects are rhinitis, rhinosinusitis, otitis media, and otitis media with effusion. And eustachian tube dysfunction is one of the etiologies for the otitis media with effusion. And approximately around 50% of the otitis media with effusion, which resolves spontaneously in 2 to 3 months, whereas about 5% they have a persistent hearing loss for about an year. And that interestingly, about half of the children with adenoid hypertrophy with otitis media with effusion are unaware of the hearing impairment. And this might cause the complications like delay in the development of the language, delay in the social behavior, and there will be learning difficulties. So this highlights the importance of the ear examination in the patients with adenoid or tonsillar hypertrophy. And regular ear examination is helping us to recognize the same. Coming to tympanometry, provides an effective screening test for the to see the middle ear status, and Puton audiometry has been the gold standard for evaluating the hearing level. Coming to the aim of the study, to study the audiological profile of the cases with adenoid hypertrophy, or tonsillar hypertrophy, or with adenotonsillar hypertrophy, and to evaluate for the hearing loss in the patients with adenoid hypertrophy, tonsillar hypertrophy, or together by Puton audiometry, and to evaluate the middle ear status, and to arrive to the diagnosis of the adenotonsillar hypertrophy, tonsillar hypertrophy, or both by the impedance audiometry, and to correlate these findings with the clinical findings. Coming to the patients and method, the type of the study is a cross-sectional study, and the study period was around January 2021 to June 2022, that is 1.5 years, and sample size is about 60, and study area is a tertiary care center in Telangana. My inclusion criteria: all the patients between the age group of 5 to 30 years with the hypertrophy of adenoid or tonsil or both, and the patients coming to the ENT OPD with the varied symptomatology of the adenotonsillar hypertrophy. Coming to the exclusion criteria, the surgically treated cases of adenotonsillar hypertrophy or previous history of an ear surgeries or any congenital anomalies of ear, nose and throat, and all the malignancies of the oropharynx and the nasopharynx. Coming to methodology, the detailed history was taken and the ENT clinical examination was done. We looked for the oral cavity and the oropharynx, and if there is any hypertrophy of the tonsils were graded according to the Brodsky scale. And if there is any suspected history of adenoid hypertrophy, the patients were subjected to the extra nasopharynx, and the grading of the adenoid was done according to the adenoid and nasopharyngeal ratio. And the otoscopy was done to see the appearance of the tympanic membrane, and the patients with the chronic adenotonsillar hypertrophy, when diagnosed, were put on to the Puton audiometry and the tympanometric examination. Methodology, the hearing impairment was classified as per the WHO classification, and in the end, the status of the hearing and condition of the middle ear and the presence or absence of the otitis media with effusion was documented for further evaluation. Coming to the results, the age of the distribution of patients with the chronic adenotonsillar hypertrophy were most of them presented around the age group of 5 to 15 years, followed by the 26 years and above till 30 years, and followed by 16 to 25 years age group. According to sex distribution of patients, females were more common presentation than the male. Around 55% of the study group of females and 45% of study group for the males. And age distribution of the patient with respect to the diagnosis, the chronic adenoiditis or chronic adenotonsillitis or chronic tonsillitis, all of them presented around the age group of 5 to 15 years, followed by the chronic tonsillitis, which presented between the age group of 26 and above. Coming to most common presenting complaints of each group, usually the adenoiditis presented with the chief complaints of mouth breathing and snoring, whereas the chronic tonsillitis and adenotonsillitis, though presented with the mouth breathing and snoring, along with that, they have presented with the difficulty in swallowing and difficulty in breathing. And none of them in my study has presented with the hearing loss. Coming to the retracted tympanic membrane, out of 120 years, 60 years were found to be retracted, of which 50% were normal and 52% were retracted, and more retraction was seen on the left-sided ear than the right-sided one. And coming to the retracted tympanic membrane, based on the diagnosis in specific chronic adenoiditis cases, 55% of the chronic adenoiditis cases were presented with the retracted tympanic membrane, whereas chronic tonsillitis patients were present. 51% of the chronic tonsillitis cases presented with the retracted tympanic membrane, and chronic adenotonsillitis were presented with 52% of the cases presented with the retracted tympanic membrane. Coming to impedance audiometric results, out of the 60 years on the right side, most of them were normal, that is a type A were normal, followed by type C and followed by type B, whereas out of 60 years on the left side, 25 years has a normal impedance, and followed by the type B and followed by type C, and one we could find as type AS type. Overall, there was more common like normal years, followed by the type C curve and followed by the type B. Coming to the Puton audiometric results, mild hearing loss according to the Puton audiometry was found both in the right-sided ear and the left-sided ear, around 36% and 23% respectively. But these are for the mild connective hearing loss, whereas moderate connective hearing loss was seen on the left side, which accounted to about 3.3%. In my study, it was seen only in the left-sided ear, and that too with the adenoid hypertrophy. Coming to the discussion, in our study, the chronic tonsillitis were more, 50%, and chronic adenotonsillitis were seen in 33%, and chronic adenoiditis were seen in 16%, around 5 to 30 age group of population, and females were more common than males. And all the three groups reported maximum in the age group of 5 to 15, and mouth breathers was the commonest presenting symptom in the chronic adenoiditis, whereas recurrent throat infection, difficulty in swallowing was seen in chronic tonsil and adenotonsillitis. And according to observation among 120 years, 62 years showed abnormal tympanogram with high proportions of the type C, that is the eustachian tube dysfunction, followed by the type B, that is the otitis media with effusion. In this study, the mild hearing loss according to PTA was revealed on the right side, that is 36%, and 38% on the left side, and moderate evaluate hearing loss according to PTA was found on the left side in around 3.3% without any complaints of the hearing loss. This proves that otitis media is a
Time
cause
up.
of silent deafness.
Next presentation by Dr. Aparna. Next presentation by Dr. Aparna.
So sharing, sir. Hello, sir. Sir, are you able to see my screen, sir?
Your screen is not visible. It's visible now. It's visible.
Okay, sir.
You have to open from one device only. You are using two devices. I think that's why there is a echo. Stops other device.
Okay, sir. Good afternoon, all. I'm Dr. Aparna, presenting a case series on allergic. It's a clinico-pathological study of serum immunoglobulin IgE, absolute eosinophil count, and nasal and pharyngeal smear for eosinophilia in allergic rhinosinusitis. Introduction. Allergic rhinitis is a global health problem which results in significant disability, and it cuts across all ages, ethnic groups, socio-economic status, and countries, estimating about 10 to 25% of the world population. It's a common disease with a prevalence of 3.5% in India, and it's an inflammatory disorder of the nasal mucosa, which is induced by an allergen exposure, which triggers the IgE-mediated inflammation. Symptoms like sneezing, itching, watery nasal discharge, and nasal blockage, and immunoglobulin IgE-mediated hypersensitivity, illness of the nasal airway. Both absolute eosinophil count and serum IgE are part of basic investigation and are known to be positively related with it, and they provide the evidence of presence of allergy. Nasal smear cytology for eosinophils is an objective investigation which involves laboratory preparation and subsequent analysis of nasal scrapings from inferior turbinate with the aim of determining the eosinophil count and categorizing such patients based on amounts seen microscopically. Aim of the study is to correlate the serum total IgE, absolute eosinophil count, and smear for nasal and pharyngeal smear in the patients with allergic rhinosinusitis. Objectives: to evaluate the serum total IgE, absolute eosinophil count, eosinophilia, nasal and pharyngeal smear, and correlate all the above three parameters in patients with allergic rhinosinusitis. It's a observational descriptive study conducted on 80 patients over a period of 18 months from January 2021 to July 2022 at Tertiary Care Hospital in Telangana. Inclusion criteria: patients of either sex aged between 10 to 60 years and with included seasonal allergic rhinitis diagnosed by area guidelines, and with allergic rhinosinusitis with polyps and with history of bronchial asthma with above symptoms. Exclusion criteria: patients with rhinitis medicamentosa and other form of rhinosinusitis where allergy is not involved, and below 10 years and above 60 years of age is not included, and any prior history of anti-allergic treatment at the beginning of the study, and pregnant and lactating mothers, and patients with carcinoma of the nose and paranasal sinuses. Methodology: it includes detailed history and clinical examination, which included anterior rhinoscopy and diagnostic nasal endoscopy. Investigations done were total and differential count at WBCs, serum IgE, absolute eosinophil count, and nasal and pharyngeal swab for eosinophilia. This is a chart showing the age distribution, where more common majority of the age group are between 30 to 39 years, followed by 20 to 29 years. Coming to gender distribution, it shows the female preponderates. In our study, it showed the 52% of the females coming in our study, mean IgE and A. In our study, mean IgA and AEC levels were found to be higher than the normal value, and only 5% of the patients, 5% of the patients showed positive for smear for eosinophilia. This is a histopathological picture of the patient showing smear for eosinophilia, where columnar cells are surrounded by eosinophils. These are the eosinophils. And in our study, comparison between the IG and smear for eosinophilia showed not significant, whereas the mean AEC value were found to be high in patients were positive for smear for eosinophilia, and it showed a positive correlation between the patients with IgE and AEC levels. Coming to discussion, allergic rhinitis is a common allergic disease with increasing prevalence developing during childhood and particularly affecting the teenagers and adults. The other studies reported a mean age of 32 years, which was close enough to the present study with the mean age of 30 years. Our study consisted of 47% males and 52% females, whereas other studies showed a male preponderance. Variations in the upper limit of normal total serum IgE have been reported to be 152,000 international units per ml, but the usually accepted upper limit is 150 to 300 international units per ml. This variation is also seen in the present study. The study was also reported increased AEC levels, which was also a similar finding. The present study showed Ig levels was not significant and AEC was significant on comparison with smear for eosinophilia. The other studies also had a similar finding with regard to absolute eosinophil count and contrary results with regard to IgE levels. The present study findings showed a moderately strong correlation between the smear for eosinophil, and other studies reported a weak positive correlation. The study was consistent with other studies which also showed an increased IgE levels and eosinophil levels. On comparison, the study showed no significant difference, which is partially similar to the present study. Coming to conclusion, the study was conducted to find out the correlation between the IgE, AEC and smear for eosinophilia. The study reported most of the patients had upper limit IgE levels and 40% had elevated AEC levels. A moderately positive correlation and association was obtained with regard to AEC, and there was no association between the IgE levels and smear for eosinophilia. These are my references. Thank you, sir.
Next presentation by Dr. Shreya Reddy.
Yes, sir. Good afternoon, judges, seniors, and my dear colleagues. This is Dr. Shreya. I am here to present a comparative evaluation of outcome of graft support material in tympanoplasty. Introduction. In otologic surgeries, the middle ear packing agent should provide temporary support for tympanoplasty repair until adequate healing and fibrous union can take place by means of maintaining stability of the temporalis fascia graft and the ossicular chain. When healing is completed, such packing should dissolve, providing optimum middle ear aeration and leaving the repaired tissue free from unwanted connective tissue adhesions, eradicating the existing pathology and creating a sound conducting mechanism in a well aerated and mucosa lined middle ear cleft are the main goals of a successful tympanoplasty. Post-operative adhesions badly affect the surgical outcome. In the present study, we investigated the effect of sodium hyaluronate carboxymethylcellulose membrane and gel foam versus only gel foam in the success of tympanoplasty surgeries. Post-operative graft success rate and airborne gap gain of the patients who underwent tympanoplasty were evaluated, and the results between the HACMC membrane and gel foam place groups and only gel foam place groups were compared. The aim of the study is to evaluate and compare the surgical outcome and hearing results in tympanoplasty surgeries according to graft support material. The results of the patients with HACMC membrane and gel foam and the results of the patients with only gel foam were compared. Materials and methods. A comparative study in which 118 patients were studied during the period of 12 months in the Department of Otorhinolaryngology. Inclusion criteria: adult patients over 17 years to 60 years who are undergoing tympanoplasty. Exclusion criteria: patients who are previously operated and patients who have systemic illness and who are not fit for the surgery. Methodology: data from 118 patients was evaluated. They were divided into two groups like group 1 and group 2. In group 1, HACMC membrane and gel foam was used. In group 2, only gel foam was used. In group 1, we have 38 patients and in group 2, we have 80 patients. Pre and post-operative clinical otological examination findings of all the patients were evaluated. Time interval between pre and post-operative period, minimum is 3 months and maximum is 12 months. In group 1, we had 38 patients. In group 2, we had 80 patients. We have 14 male patients and 24 female in group 1. We had 29 male patients and 51 female in group 2. We have used temporalis fascia as the graft in 114 cases and we used conchal cartilage in 4 surgeries. In group 1, temporalis fascia graft have been used for 32 and conchal cartilage for 2 patients. In group 2, we have used 78 patients temporalis fascia graft and 2 patients we have used conchal cartilage. Coming to the results, we had excellent results in group 1, that is 89.5. In group 2, we had the results are 71.3. In all the groups, the post-operative airborne gap was significantly improved compared to the pre-operative airborne gap. In group 1, we had 52.6. In group 2, we had 57.5. These are the 2 materials which I have used, gel foam and HACMC. Coming to the discussion, tympanoplasty is one of the commonly performed procedure in the field of otology. Adhesions in the middle ear, ossicular and implant fixation reduce the hearing. The fact makes it necessary to look for the materials against the development of the adhesions. Hyaluronic acid is naturally occurring extracellular polysaccharide possessing unique anti-inflammatory and viscoelastic properties. Within 24 hours of application, HACMC membrane turns into gel and it prevents adhesion formation and it is cleared from the body within 28 days. Gel foam is commonly used as scaffolding substance. We have excellent success rate in group 1. This can be related to the effect of hyaluronic acid on the regulation of the healing pattern of the fibrous layer and preventing of the dehydration of the perforated margins. Thus, HACMC membrane appears to be a promising graft support material. Coming to the conclusion, based on these findings, we suggest sodium hyaluronate carboxymethyl cellulose membrane as an additional option as graft support material in tympanoplasties. The positive effect on graft success rate is documented in the present study. These are my references. Thank you, sir.
Next presentation by Dr. Vandana.
Good evening, everyone. I'm going to present on clinical etiological study of hoarseness of voice. Introduction is hoarseness of voice is a symptom and not a diagnosis. Therefore, It warrants a careful determination of underlying cause in every case. The etiology ranges from trivial infections to life-threatening malignancies. Acute onset causes may be due to secondary viral infections, voice abuse, smoking, trauma to the larynx during thyroid surgeries. Chronic onset may be due to vocal polyp, vocal cord nodules, laryngeal papillomatis, laryngeal neoplasms, tumors of the vocal cord, functional dysphonias, smoking, gastroesophageal reflex, malignancy of thyroid, esophagus, lungs, and neurological involvement by systemic diseases like diabetes and TB. My aim is to find common etiological cause of hoarseness of voice. Materials and methods. It is a prospective observational clinical study. Sample size is of 100 patients from ENT OPD. Clinically, patients with benign laryngeal lesions operated appropriately depending on the detailed history, including information on patients' demographics, clinical presentation, trauma, along with history of associated medical and surgical conditions was obtained. Appropriate post-operative care was taken, followed up appropriately. Results are in this study, majority of patients were seen in the age group of 31 to 40 years of 30% and 21 to 30 years, 28%, followed by 41 to 50 years, 19%. In males are of 63 and females of 37 with male predominance, and male is to female ratio is of 1.7:1. Laborers constitute about 36%, with they constitute single largest group, followed by housewives 23%, teachers 21%, students 14%, and farmers are 6%. In this study, chronic laryngitis 50% was found to be the most common etiology, followed by acute laryngitis, vocal cord paralysis, benign tumors, carcinoma, laryngitis, and functional dysphonia. Smoking was seen in 26% of patients. Alcohol incidence was 16%, and tobacco chewing was 18%. Betel nut chewing was 5%. Females constitute 4%, and males are of 1%. Discussion. A total of 100 patients was included in our study. In our study, males 63 and females 37, with male predominance, and male is to female ratio is of 1.7:1. This study coincides with the study by Karan Sharma et al. Gaurav Kataria et al. Study, the total population was 180. Male is to female ratio is of 1.7:1. Parikh et al. Study of 100 patients showed the ratio of 2:1. Mehta et al. Study done showed ratio of 1.65:1 with male predominance. Ahmed et al. Study showed 2:1 ratio of male is to female. Baita et al. Study done on 110 patients showed male is to female ratio of 2:1. All the studies shows male predominance. In the study, majority of the patients were seen in the age group of 31 to 40 years, 30%, and 21 to 30 years, followed by 41 to 50 years. Babita et al. Found the majority of patients, 28%, in the age group of 31 to 40 years. Most of the studies shows the age group of 31 to 40 years as most common. Kaufman and Isaacson evolved the classification of vocal professions based on their voice use and risk. Level 1, elite vocal performers, where there is even a slight vocal difficulty causes serious consequences to them and their careers. Level 2, professional voice users, for whom even moderate vocal difficulty would hamper the adequate job performance. Level 3, non-vocal professionals, they perform their jobs with slight or moderate voice problems. Only severe dysphonia endangers their job performance. Level 4, non-vocal non-professionals. These are the persons who are not impeded from doing their work when they experience any kind of dysphonia. Clinical presentation and etiology. In this study, chronic laryngitis was found to be the most common etiology, followed by the acute laryngitis, vocal cord paralysis, benign tumors, carcinomas, laryngitis, and functional dysphonia. Gaurav et al. Study, Baita et al. Study, Mehta et al. Study, and Parikh et al. Study all shows the chronic laryngitis as the most common etiology. The etiology of hoarseness ranges from trivial infections to life-threatening malignancy. A sequential history, physical examination, and appropriate investigation can lead to appropriate diagnosis. Septic foci are the common precipitating factors, 42%, followed by vocal abuse, 36%, smoking, 26%, alcohol, 16%, tobacco chewing, 18%, and betel nut chewing is 5%. Chronic laryngitis, 50%, was the common etiology, followed by acute laryngitis, 21%, neoplastic conditions, 13%, neurological involvement of 10%, and male to female ratio is of 1.7:1. Laborers formed a single largest group, 36%. 3/4 patients were from the rural area. Duration of hoarseness lasted from 1 day to 5 years. Mean is of 3 months, and patient's age ranges from 21 years to 80 years. Mean is of 40 years. A patient presenting with hoarseness in ENT department may have anything from a viral infection, thus just needs a voice rest to overly malignant lesion, the treatment for which may be aggressive. Therefore, early diagnosis of the underlying cause becomes all the more important in every case. The earlier a malignancy is identified, the better the prognosis. Cessation of smoking and the usage of other tobacco preparations and alcohol can lead to significant reduction in the incidence of laryngitis and carcinoma of larynx, and in turn will reduce the burden of hoarseness. Avoidance of vocal abuse can also lead to decrease in the burden of hoarseness. Hoarseness of voice is an alarming symptom and it should not be ignored, and thorough investigation should be done to make a final diagnosis. These are my references. Thank you.
Next presentation by Dr. Vaishnavi.
Good evening, sir. We logged in from the same device, sir. Is that sir?
Hello. Please stop. The session already over. Respected judges, thank you for attending our session, sir. And chairpersons, Dr. Vishnuvardhan Reddy, sir, Subbarao, sir, thank you for coming. And our next session will start within half an hour. Dr. Manoj.
Yes, sir.
Thank you.
Yeah, already more than 15. The 15 candidates over, I think. I told you 14. After 14 candidates, the session will over. Anyway, Thank you, judges, for your patience. 15 candidates over. Just within 20 minutes to 30 minutes, we will start.
Sure,
let other judges will join. Sriharsha? Sir, Nagaraj sir, thank you so much. Anil Kumar sir, thank you so much, sir.
Thank you, sir. Thank you.
You can exit now, sir. All the postgraduates, we are remaining candidates, please join and just check your presentation in this gap.
Dr. Ramesh.
Yes, sir. Yes, sir. Thank you so much, sir. Yes, sir.
Thank you so much,
sir,
Ramesh.
Sir, Subbarao, sir. One clarification, sir. All the judges are from outside our state only. There is no such clash, sir. Every judge is from different state only, sir. I arranged like that only, sir. Thank you, sir. Vishnuvardhan Reddy, sir. Sriharsha? Sriharsha, are you there? Harsha Leda. Manoj?
Yes, sir.
నేను ఒక 15-20 minutes లో మిగతా జడ్జెస్ జాయిన్ అవుతారు. వీళ్ళని జస్ట్ చెక్ చేసుకోమని చెప్పు. వన్స్ జాయిన్ అవ్వగానే, ఎందుకంటే మనం ఎర్లీగానే అయిపోయింది, ఎర్లీగా స్టార్ట్ చేసాం కదా, కొంచెం ఎర్లీగానే అయిపోయింది. సో అట్లా చూసుకోమని, ఏమైతే మిస్టేక్ చేస్తున్నారు చాలా హరీబరీగా ప్రజెంట్ చేస్తున్నారు. మెజారిటీ ఆఫ్ దెమ్ ఎవరో తరుముతున్నట్టు కాకుండా కూల్ గా ప్రజెంట్ చేయమని చెప్పు. టైం స్టిక్ ఆన్ టు టైం. ఈ లోపల ఒకసారి ఆడియో ప్రాబ్లమ్స్, వీడియో ప్రాబ్లమ్స్ అయితే రెక్టిఫై చేసుకోండి. అంటే లింక్ లోనే ఉండండి. నేను జస్ట్ అనౌన్స్ చేస్తాను మళ్ళీ ఒక 15 మ్యాక్సిమం 4:20కి మళ్ళీ రెజ్యూమ్ చేద్దాం.
ఓకే సార్.
థ్యాంక్ యూ. నేను అనౌన్స్ చేస్తాను, ఆన్లైన్లోనే ఉంటాను.
ఓకే,
థ్యాంక్ యూ.
Dr. Vaishnavi, please check your PPT once. Dr. Vaishnavi, please check your PPT.
Is it visible, sir?
Yeah, it's visible. Better if you can full screen the PPT.
Okay, sir.
Okay, it's visible.
Okay, sir.
Dr. J. Mohana, please check your PPT. Dr. J. Mohana.
Sir, yes, sir. Share.
Please check your PPT.
Yes, sir. Sir, is it visible?
It's not visible as of now.
Okay, sir. Just a second. Now, sir?
Yeah, it's visible.
Okay, sir.
Make it full screen.
Okay, sir.
While presenting, make sure you turn on your video.
Okay, yes, sir. Yes, sir. Now, do I have to present now, sir?
No.
Okay, yes, sir.
You can just check your PPT if it is displaying or not.
Yes. Yes, sir.
Okay.
Yeah.
Dr. Monica, please check your PPT.
Yes, sir. Yes, sir. I'm checking. Sir, is it visible, sir?
Yeah, it's visible.
Yes, sir.
Dr. Vrinda. Dr. Vrinda Ullas, please check your PPT.
Sir, Vrinda won't be presenting, sir. She's unwell.
Okay. Dr. T. Pramod, please check your PPT.
Sir, is it visible, sir?
Yeah, it's visible.
Okay, sir.
On your video also.
Okay, sir.
Okay, right. Dr. Chaitanya, please check your PPT. Dr. Chaitanya, please check your PPT. Dr. Anusha, please check your PPT. Dr. Anusha, please
Sir.
check your PPT.
Okay, sir. Okay. Sir, is it visible?
There's an echo from your side. Make sure you play only on one device.
Sir, mouse.
Yeah, it's visible.
Sir, repeat okay, sir.
Yeah, your AV is good.
Sir.
Dr. Balaji.
Visible, sir?
Dr. Balaji, please turn on your video also.
Okay. Visible, sir?
Yes, it's visible. It's visible.
Okay.
Dr. Madhumita, please check your PPT.
Yes, sir. Is it visible, sir?
Hello, Harika. Time button.
Sir, visible, sir. Sharing your screen. Sir.
It's visible. Please turn on your video also.
Yes, sir.
Okay. Hello.
Sir.
Okay.
Is it okay, sir?
Yeah, it's visible. It's visible. It's visible.
Yes. Thank you.
Dr. Bhanu. Dr. Bhanu, please check your PPT. Dr. Bhanu. Dr. Ravali, please check your PPT.
Yes, sir. Sir, visible, sir.
Yeah, it's visible. Turn on your video also.
Okay, sir. It is on.
Okay, right.
Okay. Thank you.
Dr. Asha. Dr. Asha.
Yes, sir. Yes,
please
sir.
check
Yes,
your
sir. One
PPT.
second. Yeah, sure. What's that is not coming? Coming?
Open PPT.
1 second. Here it is. Yeah. Sir, is it visible, sir?
Open your PPT once.
Sir, is it visible, sir?
Only screen is visible. Your
I hope
PPT is not
actually.
visible. Open your PPT.
Yeah, 1 second. I'll show play. Now? Now it is coming, sir?
It's visible. It's visible.
Yeah. Okay, sir. Thank you.
stop sharing. Yeah.
Dr. Aarti ma'am, please share your PPT.
Hello, am I audible?
Yes, ma'am, you are audible.
Yeah, just a second. Is it coming full screen?
Yes, ma'am.
Yeah, okay. Thank you.
Dr. Bhanu, please check your PPT. Dr. Bhanu. Dr. Bhanu, are you there? Dr. Vaishnavi, please share your PPT. Dr. Vaishnavi, please share your PPT.
Yes, sir, 1 minute. Is it visible, sir?
Yeah, it's visible.
Yes. Should I start now, sir?
Oh, no.
Okay.
I'll tell you when to start.
Okay, okay, sir.
Yeah, good evening, everyone. Are you ready with presentation? Manoj? Manoj, am I audible?
Sir.
Yeah.
Yes, sir.
Are you able to?
Yes, sir, you're audible.
Hello. Okay, Manoj. Yeah. Next session will sharply start by 4:30. The chairpersons are Dr. S. Ramakrishna, sir, retired professor and HOD of Usmania Medical College, and Dr. Maheshwar Reddy, sir, assistant professor of Usmania Medical College. By 4:30, I will announce the judges' names. They will come. You can start the program.
Okay, sir.
Dr. Maheshwar Reddy, sir, are you there?
ముగ్గురు మేడం కానీ ఇప్పుడు వచ్చేది ఇద్దరే మేడం బస్కి వెళ్తున్నారు
ప్లే చేయండి నా వైఫ్ కి నేను డెడికేట్ చేయాలనుకుంటున్నాను అని చెప్పేసి మెసేజ్ చేశాను. డెఫినెట్ గా ప్లే చేస్తాను. అండ్ అలాగే మీరు కూడా ఈ సాంగ్ ఎవరికైనా డెడికేట్ చేయాలనుకుంటే 7337441064 కి వాట్సాప్ చేయండి లేదా
ఏదో ప్రస్తుతానికి తర్వాత చూద్దాము మళ్ళీ ఎవరైనా జాయిన్ అయితే అప్పుడు మారుద్దాంలే అంటున్నాను. రేపు సుద్దా సార్ కానీ విక్రమ్ సార్ కానీ వస్తే అప్పుడు చూద్దాంలే అంటున్నాను.
Ultra fast sitting cement.
ఆల్రెడీ దానిలోకి ఒక వెహికల్ పోతుంది మేడం అదే కాలనీలోకి అయితే అది పెద్ద వెహికల్ ఇచ్చేసేదా బాబు అంటే ఈనాడు ఆ డ్రైవర్ ఈనాడు చిన్నదంటే 5 సీటింగ్ మేడం అదే అనిల్ చిన్న పిల్లోడు వెళ్తారు కదా సిమెంట్ కలర్ 0344 బండి కాదు ఇదే ఇన్నోవానే అది బకెట్ సీట్లు అనమాట 5 వెళ్తారు దాంట్లో
మనోజ్
ఎప్పటి నుంచి ఉన్నారు మేడం
హలో మనోజ్
సార్ హలో
మ్యూట్ చేసుకోవాలి వేరే వారి వాయిస్ మ్యూట్ చేసుకోమాను
ఓకే సార్
సార్
మొబైల్ డేటానా మొబైల్ డేటా ఇది వస్తలేదు ఇది
విశ్వనాథ్ రెడ్డి సార్ ఉన్నట్టున్నారు ఇంకా విశ్వనాథ్ రెడ్డి సార్ విశ్వనాథ్ రెడ్డి సార్ Yeah. Hi everyone. Welcome Dinesh sir. Good evening sir. Dinesh sir. Are you there? Mahesh Reddy sir. Mahesh Reddy sir.
I am present.
Mahesh Reddy sir ఉన్నారా? Sir Dinesh sir.
రమేష్ ఉన్నాను.
Mahesh Reddy sir.
ఉన్నాను.
sir.
ఉన్నాను
ఈ
బాస్.
సెషన్ కి మీరు చైర్పర్సన్ గా ఉంటున్నారు సార్. మీతో పాటు ఎస్ రామకృష్ణ సార్ కూడా వస్తున్నారు. రామకృష్ణ సార్ జాయిన్ అవుతారు. సో ఈ సెషన్ స్టార్ట్ చేద్దాము. జడ్జెస్ కూడా వస్తున్నారు.
ఓకే.
Hi Ramesh, good morning.
Good evening, sir. Sir David sir, welcome sir.
Good evening, David here.
Manoj.
Sir,
David
good morning,
sir, welcome sir. Yes sir, welcome sir.
Welcome sir.
I'm sorry, it is a very what is called as nice surrounding. Hi Manoj. Good morning.
Sir, good evening sir.
Hello.
మ్యూట్ చేసినారా? మ్యూట్ చేసినారా? దాన్ని మ్యూట్ చేసేయండి.
రమేష్. రమేష్. రమేష్.
Manoj,
Sir,
please invite the judges and give brief CV about Dinesh sir.
okay, sir. Welcome, Dinesh, sir. Dr. Dinesh Walse, he is from Gulbarga. Sir has done a fellowship in otology from France and Coimbatore, and fellowship in rhinology and facial plastic surgery from South Korea. Sir has done a lot of research and publications in the national journals and conducted courses and workshops. Please welcome, sir.
And also David sir, welcome sir. More popular, he is also more interested in otology, has done excellent work in the otology. Like my brother, David sir. Okay, you can go ahead, Manoj.
Okay, sir.
Sir will,
so I would like to call upon M. Vaishnavi.
Yes, sir.
Please turn on your video and start your presentation.
Yes. Am I visible, sir?
Yeah.
Good evening, everyone. Today my topic is a sensory neural hearing loss in traffic police due to noise pollution. One minute, sir. Introduction. Hearing loss results from damage to structural hair cells in inner cell due to noise exposure is termed as noise-induced hearing loss. It can be caused by one-time exposure to loud sound or from exposure to loud sounds over an extended period. Hearing loss may be temporary or permanent. It is characterized by a dip in 4 kHz accompanied with a tinnitus sometimes. Permanent hearing loss develop as a result of longer and continuous exposure of damaging noise levels that is more than 85 decibels, which causes irreversible morphological changes in hair cells. Noise-induced hearing loss depends on intensity, frequency, and duration of noise exposure. Tune audiometry is the cornerstone of investigation to find out noise-induced hearing loss. Aims and objectives. To assess the instance of sensorineural hearing loss among traffic police personnel and also to evaluate the duration of noise exposure with respect to the development of hearing loss. Materials and methods. This is a prospective study carried out at traffic police stations near medical college during the period from July 2020 to July 2022. A total of 100 patients were included in the study. Inclusion criteria. Traffic police personnel with age group of 30 to 55 years were included with 3 to 15 years of exposure to noise. And exclusion criteria is traffic police personnel having a hearing loss due to infectious, neoplastic and congenital causes are excluded. Method of collection of data. A written and informed consent to be included in the study was obtained in patient's own language. Each patient was subjected to detailed history taking and examination. Each patient underwent otoscopic examination of ears, tuning fork tests, and also the pure tone audiometry. This is the PTA report of one patient showing normal hearing levels with a dip in 4 kHz, which with only 3 years of experience. 3 years of exposure to noise. And also this is also other patient's audiogram showing dip in 4 kHz with mild and moderate sensorineural hearing loss in both ears. These are the results. In right ear, with the patient having no symptoms and also PTA shows normal, the cases are regarded as 62. No symptoms but PTA shows mild hearing loss, the cases are number 3. Tinnitus only presents as a symptom, but PTA is normal. The cases are recorded as 4. Tinnitus only with PTA mild hearing loss, cases are 14. Mild hearing loss with the PTA shows moderate hearing loss, the cases are 9. Severe hearing loss, the cases are only 1. This is the same thing which is showed in the graph. In the left ear, PTA and there is no symptoms, the cases are 57. No symptoms, but PTA shows mild hearing loss is 3 cases. Tinnitus as a only complaint, but PTA is a normal, there is no cases. With symptom as tinnitus, but PTA shows mild hearing loss, the cases are 20. Mild hearing loss and the PTA shows mild hearing loss, the same symptom, patients are 11. Moderate hearing loss, the cases are 8, and severe hearing loss, only the 1 case is recorded. This is the graph showing the same dose of cases. This is the tinnitus, showing the graph which shows exposure of now years of exposure versus age group. As the age advanced, the tinnitus is increased. This is the hearing loss. This is also the graph which shows years of age related to the number of patients. In this also above 45 years of age, 73 out of affected people, 73% were affected. This is exposure versus hearing problems. Up to 3 to 5 years of exposure, 89% is normal. The patient showing tinnitus as complaint are only 11% with no hearing loss. For 6 to 10 years of exposure, 75% were normal, 32% show symptoms as tinnitus, and hearing loss mild, 8% they are having mild hearing loss and 4% having moderate hearing loss. With 11 to 15 years of exposure, 36% shows normal. Tinnitus as a symptom, they have 28%, with mild hearing loss is 13%, moderate is 21%, and severe is 3%. In the discussion, in a present study sample, size is 100 with age distribution between 30 to 55 years of traffic personnel with 3 to 15 years of exposure to noise. Incidence of tinnitus is increased as the age advanced. Number of cases and a degree of hearing deficit increased as the age advanced. Bilateral hearing loss was more common when compared to unilateral hearing loss. In case of bilateral is 48% and unilateral hearing loss is only recorded as 16%. Another prospective study was conducted in Abbasi Shahid Hospital, Karachi. About 200 selected subjects were studied. Among 74 traffic constables as cases, 126 shopkeepers as control. Age group is 15 to 80 years. In that, incidence of noise-induced hearing loss was 33.81%. My conclusion is all the patients were underwent pure tone audiometry. The following observations were made. Out of 100, only 11% were affected after 3 to 5 years of exposure to noise. After 6 to 10 years of exposure to noise, 25% were affected. After 11 to 15 years of exposure to noise, only 64% were affected. Out of totally affected people, 73% were above the age of 45 years. So there was a considerable relationship between the duration of noise exposure and hearing loss. More than 5 years of work caused a significant hearing loss. So the benefits to the community, by making this thesis, we can do the early diagnosis, better patient care, awareness to traffic police personnel about noise exposure and hearing loss. It also highlights the importance of wearing the protective devices during the working hours to prevent noise-induced hearing loss. And these are my references. Thank you, sir.
Any questions, sir? Okay. Next presenter, J. Mohana.
Thank you.
Good afternoon, sir. Good afternoon, sir.
ఏమన్నా ఉంటుందా? హలో వర్ష, అయిపోయింది ఇప్పుడే. పోదాం.
Please mute yourselves. Jay Mohana?
Yes, sir.
Start your
Can I
presentation.
Yes. Good afternoon, sir. I'm Mohana and I will be presenting complications of otitis media in the present times. Otitis media being an age-old disease, in the pre-antibiotic era, we could only provide systemic, only symptomatic relief to the patient. After the advent of antibiotics, we are able to provide a better prognosis for the patients. But even in the 21st century right now, there are still complications of otitis media prevalent. Otitis media is more common in the lower socio-economic strata, and with advent of antibiotics, the management has definitely been improved. Prior to the antibiotic, the intracranial complications have shown to insist of around 2.3 to 4% cases, and after antibiotic era and the new surgical techniques, the complications have been greatly reduced to 0.15% to 0.4%, and the mortality has reduced dramatically to 8%. Despite the overall decline in the incidence of complications of otitis media, we still need to be vigilant to look for any complications, because along with the use of antibiotics, even the patient's resistance to antibiotics has increased, the virulence of organisms have increased, and it also depends upon how we handle each patient. So every patient is different. Even with the use of antibiotics, we need to be vigilant about the complications. The aim of the study is to analyze the various clinical presentations of otitis media and its related complications. I have included the patients with irrespective of age and gender, with intracranial or extracranial complications or both, who are giving positive consent for the study. Exclusion criteria are patients who have not given consent for the study, and pregnant females. I have collected around 12 patients of otitis media with complications over a period of 1 year. All underwent a detailed history examination and endoscopic examination, and routine surgical profile and radiological investigations like computer tomography, temporal bone, and for intracranial complications, magnetic resonance imaging of the brain was done. All patients patients with active discharge underwent pus for culture sensitivity, and antibiotics suitable for that have been given. The classification of complications of otitis media, there is intracranial and extracranial. Intracranial include extradural abscess, subdural abscess, meningitis, brain abscess, lateral sinus thrombophlebitis, and otitic hydrocephalus. I have seen about 2 cases of brain abscess and 1 case of lateral sinus thrombophlebitis. Among the extracranial complications, I have collected 2 cases of mastoiditis, 3 facial paralysis, 3 subtotal periosteal abscess, and 1 basal abscess case. In my cases, there have been predominantly males, that is 7 males and 5 females, and the age group is common along the younger age group, that is below 18 years. I have collected 8 cases. The common symptoms and signs seen which point towards extracranial are post-oral swelling, neck swellings, mastoid tenderness, protrusion of pinna, and mouth deviation. And each patient had among 12 patients, 4 patients had post-oral swelling, 1 neck swelling, 8 mastoid tenderness, 7 protrusion of pinna, and 3 mouth deviation. The intracranial complications, the patients have presented with headache, altered sensorium, vomiting, and neck stiffness. Patients you cannot differentiate the patients based on intracranial and extracranial based on otalgia, otorrhea, fever, and hard of hearing, because both the patients had a common symptoms. The first case is mastoiditis. This is a 17-year-old male patient who presented with pain over the post-oral region, with the swelling of the post-oral region, and he had ear pain and ear discharge since 45 days. Here on examination, you can see outward protrusion of the pinna. There is obliteration of the retroauricular groove, and on autoendoscopic examination, there is an anterior perforation with active discharge. He had been treated with culture-specific antibiotics for a period of 6 weeks, and after 6 weeks, there was still soft tissue in the mastoid and the CT temporal bone. He underwent cortical mastoidectomy and tympanoplasty. This is another case of subperiosteal mastoid abscess. This is a 25-year-old male patient who had again right mastoid tenderness and swelling since 15 days. He had a history of ear discharge over a period of 6 months, and on examination there is outward and forward protrusion of the pinna, and there was a soft swelling in the post-auricular region, tender, and there is local rise of temperature. The patient had underwent incision and drainage. The pus was sent for culture sensitivity, and adequate antibiotics was given. Even after 6 weeks, there was soft tissue in the mastoid, and he underwent cortical mastoidectomy plus tympanoplasty. This is a case of basal abscess. The patient presented with a ear discharge since 6 months and swelling over the neck since 15 days. He underwent incision and drainage. And on otendoscopic examination, there was a grade 4 attic retraction with cholesteatoma flakes. And there was a cholesteatoma on the CT scan. He underwent canal wall down mastoidectomy. This is a video showing the pus oozing out of the mastoid tip. The complete abscess was drained along with the cyst wall was removed. He responded well. Then mastoiditis with facial palsy. This patient presented with post-oral tenderness and grade 2 facial palsy. He had pus in the ear and he was treated with antibiotics. His facial palsy improved after 2 weeks of antibiotic course. But on CT temporal bone, there was a soft tissue scan, soft tissue and cholesteatoma in the mastoid with granulation tissue in the posterior quadrant. And he was treated. He underwent canal wall up mastoidectomy, and the patient is doing good, and his facial function has also improved. This is a case of congenital cholesteatoma who presented with recurrent facial palsy. She had a cholesteatoma, and she underwent canal wall down mastoidectomy. She also had tegmen plate erosions and sigmoid plate erosions. After 3 months, she presented with a cerebellar abscess with altered sensorium, and she was sent to the neurosurgical team for the drainage of the abscess. We lost the patient to follow-up. It's a case of cholesteatoma adult patient with the facial palsy. On CT scan, there was an extensive cholesteatoma, and she underwent this is the cholesteatoma sac, and she underwent canal wall down mastoidectomy. And
1 minute left.
Yes, sir. And her facial function has improved. This is a case of cerebellar abscess. The patient presented with ataxia and altered sensorium with extension to the posterior cranial fossa. Neurosurgery people have done a partial craniectomy, and there was a cholesteatoma sac, and we have done a canal wall down mastoidectomy. This is a case of sigmoid sinus thrombosis. The patient presented with edema of the mastoid with ear discharge. On MRI brain, they showed sigmoid sinus thrombosis. We did a canal wall up mastoidectomy. The thrombus was aspirated until clear blood was seen. Otitis media is the inflammation of the mucoperiosteal lining of the tympanomastoid compartment. The complications denote spread of infection beyond the mucosal cleft. I saw 6 patients had cholesteatoma sac. Common organisms were Pseudomonas and pneumococcus. 3 underwent canal wall down mastoidectomy. 4 underwent incision and drainage. Among my complications, 75% has extracranial. The main are mastoiditis and facial nerve paralysis. Among intracranial, brain abscess was common. Conclusions.
Dr. Mohana, your time is up.
Yes, sir.
Yeah. Next presenter, Maunika Reddy. Maunika Reddy, share your screen.
Sir, is my screen visible, sir?
Yes.
Yes, sir. Good evening, everyone.
Start.
Sir, shall I?
Start.
Good evening, everyone. Today I'm going to present a case series on a role of bevacizumab in recurrent respiratory papillomatosis. Recurrent respiratory papillomatosis is also known as laryngeal papillomatosis. It is caused by human papilloma virus 6 and level. It is characterized by papillomatous growths in the entire respiratory tract. It is predominantly a benign disease, and malignant transformation can be observed in 3 to 7% of patients. Current treatment options for recurrent respiratory papillomatosis usually involve microdebriders and laser application. Bevacizumab is a monoclonal human antibody which inhibits the binding of vascular endothelial growth factor and its receptor, thereby influencing the growth of papilloma. Bevacizumab is considered as a promising adjuvant therapy to surgery. Aims and objectives to study the role of intralesional bevacizumab in recurrent respiratory papillomatosis. 4 patients aged 18 months to 18 years with severe recurrent respiratory papillomatosis requiring multiple surgical debridements were included in this study. Patients were excluded if they had undergone fewer than 4 procedures per year and if they didn't want adjuvant therapy or had a known sensitivity to bevacizumab. A special informed consent was taken from the families regarding risks and benefits of intralesional bevacizumab treatment. Dosage of bevacizumab used is 1 ml each interval once every 4 to 6 weeks with a concentration of 2.5 milligram per ml. Intralesional bevacizumab is diluted in normal saline and it was given with laryngeal needle under general anesthesia with the help of suspension laryngoscope. Results. Case 1, the first case is a 3-year-old boy who was first diagnosed with recurrent respiratory papillomatosis when he was 1 year old and required a tracheostomy tube 1 month later due to severe obstruction of the airway. He underwent multiple surgical procedures for a period of 2 years without any clinical improvement. Later, when he was 3 years old, patient was treated with intralesional bevacizumab along with the surgical debridement at a dosage of 1 ml 3 intervals 4 weeks apart, and patient was on follow-up for 6 months, which showed no evidence of papillomas and improvement of quality of voice. Okay, this is a pre-op picture showing the papillomatous growth and the post-op after the intralesional bevacizumab. Case 2, the second case is an 18-year-old boy who was first diagnosed with papillomatosis when he was 15-year-old. When he presented to our OPD with sudden hoarseness of voice, he underwent multiple procedures for a period of 3 years with clinical improvement, but there was rapid growth of papillomas. Later, when he was 18 years old, patient was treated with intralesional bevacizumab along with surgical debridement at a dosage of 1 ml 3 intervals 4 weeks apart, and patient was on follow-up for 1 year, which showed slow growth of papillomas and improvement of quality of voice. This is a preoperative picture of papillomas and the post-op after bevacizumab. The third case is a 3-year-old boy who was first diagnosed with recurrent respiratory papillomatosis when he was 2-year-old and required an immediate tracheostomy as child presented to our OPD with stridor. He underwent multiple surgical procedures for a period of 1 year. Later, when he was 3-year-old, patient was treated with bevacizumab and he was followed up for 1 year, which showed no evidence of papillomas, and the child is being followed for the plan of decannulation after 1 year. Preoperative and postoperative. The fourth case is an 8-year-old female patient who was diagnosed with respiratory papillomatosis when she was 5-year-old. When presented with hoarseness of voice, she underwent surgical debridement for a period of 2 years. Later, when she was 8-year-old, she was treated with intralesional bevacizumab, and it showed improvement of quality of voice, and the number of procedures, surgical procedures per year also decreased. Preoperative and postoperative pictures. Discussion. Recurrent respiratory papillomatosis is extremely challenging disease in children. Most common presentation is hoarseness of voice, and some children may present with the stridor from airway obstruction by the papillomas. To maintain an adequate airway, repeated surgical procedures are performed at the expense of scarring and permanent voice disturbance. While surgery is the main treatment of choice, 20% of the patients may require adjuvant treatment. Adjuvant treatment options include oral indole 3-carbinol, mumps vaccine, intralesional cidofovir, and bevacizumab. Indications for adjuvant therapy are the need for more than 4 surgical procedures per year, rapid regrowth of papillomas with airway compromise, or distal spread of the disease. Bevacizumab, Avastin, is a human monoclonal antibody that binds to vascular endothelial growth factor and inhibits its interaction with their receptors, and thereby helps in slowing the growth of papillomas. In our study, patients who were treated with intralesional bevacizumab injections required fewer surgical procedures per year and showed an increase in the duration of time between the procedures by 6 to 8 weeks. Derkay staging also decreased. The voice outcomes also improved after bevacizumab, thereby improving the voice-related quality of life of patients. These results were seen even with very low doses of bevacizumab. Of course, our study do not focus on any reliable conclusions on safety and the potential of malignant transformation in patients undergoing long-term treatment with intralesional bevacizumab. Conclusion: adjuvant treatment with intralesional bevacizumab appears to have promise in the most treatment-resistant and aggressive forms of papillomatosis with low complication. However, regular screening for malignant transformation and side effects must be considered in all patients undergoing long-term treatment. These are my references. Thank you.
Sir, any questions? Next presenter, T. Pramod Kumar.
Sir, is my screen visible, sir?
Yeah. Make it full screen.
Okay, sir. Sir, is it visible, sir?
Yeah, start your presentation.
Myself, Dr. Pramod. Today I am going to discuss about my study, a study on efficacy of autologous platelet-rich plasma in type 1 tympanoplasty. Introduction. Chronic otitis media is a chronic inflammation of the mucoperiosteal lining of the middle ear cleft. The patient presents with the persistent or intermittent discharge followed by hearing loss. It is more prevalent in lower socio-economic groups. It is more common in rural population compared to urban population because of unhygienic practices. The prevalence rate is 46 and 16% per 1,000 in rural and urban population. The chronic otitis is two types, that is active and inactive type, depending on discharge. It is associated with tympanic membrane perforation. The classification of the chronic otitis media is healed chronic otitis media, which is tympanosclerosis, and the inactive chronic otitis media, which is mucosal type, which has perforation, and inactive chronic otitis media is a squamosal type. Active COM mucosal type. Active COM squamosal type is a cholesteatoma. The tympanic membrane perforation results from acute suppurative otitis media, chronic otitis media, and the trauma are the iatrogenic. We need thorough audiological and radiological evaluation. Before going type 1 tympanoplasty, the patient is given antimicrobial therapy and the infection is taken out. The prerequisites for the meringoplasty is the patency of the eustachian tube, good cochlear reserve, and the mobile round window membrane. Then in our study, we went with post-auricular incision along with the temporalis fascia graft. The success rate is 70 to 90%. We need novel methods to increase the graft uptake and the outcomes. The role of platelet-rich plasma. The platelet-rich plasma has growth factors. It has 95% platelets when compared to the normal blood. It is simple and easily preparable and minimally invasive method. It helps in healing of the tympanic membrane perforation because it has the growth factors like the transforming growth factor, platelet-derived growth factor, vascular endothelial growth factor. It is placed on the lateral surface of the graft and tympanic membrane remnant. Then it is held in position with the gel foam and the ear canal is packed with the earwig. Then the preparation of the autologous platelet-rich plasma. It is done with the 16 or the 18 gauge syringe. 5 ml of blood is taken from the peripheral blood after induction of the anesthesia. It should be underwent centrifugation of 3,200 rotations per minute for 12 minutes. It is divided into 3 layers. The platelet poor plasma, which is upper layer, and the middle is the platelet-rich plasma, along with the buffy coat of the WBC. The lower layer is the red blood cells. It is placed in the ear canal lateral to the graft. My aim is to study the efficacy of autologous platelet-rich plasma in closure of the tympanic membrane perforation during type 1 tympanoplasty by preventing the graft displacement, promoting quicker healing, improving the overall outcome. My objectives are to compare graft uptake post-operatively following type 1 tympanoplasty with and without PRP, and to compare the pre and post-operative audiological benefit at 3 months follow-up. Material methods. Study design is a prospective study. Then I studied the patients who have come to the ENT department at my institutions. The study population is 50 patients. The study period is 18 months. The inclusion criteria is chronic otitis media, inactive mucosal disease, who is having central perforation with dry ear for at least 6 to 8 weeks. The exclusion criteria is children below 12 years of age and active ear disease, diabetes mellitus, and systemic diseases like autoimmune disease, neoplastic disease, patients on immunosuppressant. Data collection is I took 50 patients and they were grouped into group 1 and group 2. The odd number went for type 1 tympanoplasty with PRP and the even number underwent type 1 tympanoplasty without PRP. I took the thorough history taking and clinical assessment and Puton audiometer to know the degree and the degree and the type of the hearing loss, X-ray master to rule of the to see the cellular of the mastoids. My study focused on the use of the prepaid autologous platelet plasma placed on the lateral surface of the graft and tympanum membrane. The results are, my study included much of the population in between 21 to 30 years of age, and most of the patients are female patients, and most of the patients are having unilateral ear disease. So among the cases, much of the patients has subtotal perforation. Among controls, much of the patients have large perforation. And the graft uptake status, the failure rates is 4 patients. Failure rate is seen in 4 patients out of 25 in cases, and among controls 8 out of 25. The audiological assessment was done in both cases and controls. The audiological assessment was better when compared to the controls at 3 months of follow-up. More than 10 decibels were achieved in the cases with PRP. Graft uptake comparison with other studies. Wahed Elanwar has success rate of 100% in cases, and Shankar has 96%, and my study has 84% of success rate in cases. Discussion: PRP has growth factors in high concentration in whole brain. PRP enhances the healing process and does not have side effects. It can be harvested through a simple method without any additives. It can be kept, the graft can be kept in position, avoid sagging of the posterior canal wall, and prevents complication associated with ear canal pack. In my study, we analyzed functional results in patients suffering from chronic otitis media who underwent meringoplasty with and without PRP. There is graft uptake rate, clinical improvement, and audiological benefit more than 10 decibels, more in cases than controls. The graft uptake is more for medium central perforation. Graft uptake rates are less in both cases and controls in my study when compared to other studies. The take-home message is platelet-rich plasma is a platelet concentrate with enriched growth factors. Helps in tympanum membrane closure following meringoplasty. It prevents the displacement of the graft from site. It has no noticeable side effect. This study shows there is a definite benefit by using PRP in meringoplasty. So PRP is easily prepared, and PRP meringoplasty can be routinely performed. Here are my references, and thank you.
Sir, now you can ask questions, sir. Sir, shall I go for the next presenter, sir? Next presenter, Dr. Chaitanya PM from Usmania Medical College. Dr. Chaitanya. Which is not online. I would like to call the next contestant, Dr. P. Anusha. Dr. P. Anusha, please start your presentation.
Okay.
Dr. P. Anusha.
Sir, is it visible, sir?
Yes. Your time starts now.
Sir, good evening, sir. My topic is role of Posacol in treatment of post-COVID-19 rhino-orbitocerebral mucormycosis. Rhino-orbitocerebral mucormycosis is an acute aggressive invasive fungal sinusitis occurring in individuals with impaired immunity, most commonly due to uncontrolled diabetes, and manifests itself as a nasal stiffness, nasal discharge, facial pain and numbness, periorbital swelling and proptosis. Other risk factors include neutropenia, immunosuppressive therapy, hematological malignancies, transplantation and serum iron excess. Mucormycosis is an aggressive, acutely infective, opportunistic granulomatous fungal infection which class Zygomycetes, order family is Mucaraceae. Pathophysiology of mucor is post-COVID is mainly due to marked raised pro-inflammatory cytokines, hypercoagulable state, increased iron overload due to disturbed iron metabolism. Almost all patients had history of COVID-19, poor diabetic control, history of steroids and oxygen support during COVID-19 treatment. For demonstration of fungus, TSCON involving facial bones and paranasal sinuses, orbit and brain aids in effective treatment planning and progression of disease. Treatment includes reduction with surgery, appropriate antifungal therapy, and reversal of the immunosuppression wherever is possible. After surgical debridement, prolonged antifungal therapy is crucial. First-line systemic antifungal agent include amphotericin B and its lipid formulation, but on prolonged usage, it causes renal function deterioration. Due to amphotericin B's fatal side effects, posaconazole can be used as an alternative treatment for the mucormycosis. Posaconazole is a systemic triazole antifungal drug derived from the atraconazole. Tmax of posaconazole is 3 to 5 hours. Half-life is 35 hours. Posaconazole inhibits cytochrome 450, which inhibits ergosterol synthesis, which is a key component of fungal cell membranes. Accumulation of methylated sterol precursors leads to cell death. 3 formulations are currently available, namely oral suspensions, delayed release tablets, intravenous formulations. Our study demonstrates clinical utility of posaconazole as a therapeutic agent in rhino-orbital cerebral mucormycosis in predominantly diabetic population. Materials and method. This is a retrospective study, includes 50 patients with post-COVID ROCM who had been treated with posaconazole in our hospital. Patient details including clinical presentation, comorbidities, culture findings and CT imaging, duration of posaconazole use, duration of follow-up and outcome were noted. Diagnosis was made by clinical examination, diagnostic nasal endoscopic, KOH mount, CT imaging of paranasal sinuses, orbit and brain. Patients were treated with injection posaconazole 100 mg IV TID for 7 days. Surgical debridement was done. Few patients underwent maxillectomy and patients were continued with tablet posaconazole 300 mg for 3 to 6 months with LFT RFT monitoring. Patients were followed up for 4 to 6 months and inferred that patients had complete resolution of clinical symptoms. Inclusion criteria: all patients who presented with signs and symptoms of mucormycosis, all patients screened for COVID hypertension and one is infectious. Remaining patients had no comorbidities. Out of 50 patients, 23 patients were on steroid, 17 patients were on oxygen, 20 all patients were admitted within 2 weeks of COVID infection recovery. 45 patients underwent functional endoscopic sinus surgery. Remaining 5 underwent functional endoscopic sinus surgery plus partial to subtotal maxillectomy, and all patients were treated with to its intrinsic ability in the blood vessels. The fungus causes thrombosis and ischemia to region affected. In patients with diabetic hyperglycemia causes glycosylation of transferrin, and transferrin reduces the iron binding by reducing the ability to transferrin formulation available as an oral preparation, which can be used as a first-line agent in management of mucormycosis. According to George, posaconazole treatment for mucormycosis, the drug was frequently and successfully used in combination with surgical debridement. In our present study, we have distributed patients affected with mucormycosis based on their comorbidities treatment taken during their COVID infection period, which explains the causative factor for the mucor post-COVID-19. Causal Leon et al. Proposed an algorithm for the diagnosis and treatment for ROCM in patients with diabetes mellitus. The red flags warning signs in this algorithm are sinus pain, cranial palsy, diplopia, periorbital swelling, orbital apex syndrome, and palatine ulcer. Any of these signs must prompt the clinician for immediate further testing and initiation of fungal therapy and to advise the surgical protocol. Chaos wet mounts is a rapid and inexpensive method to demonstrate the fungus. It is high importance intraoperative to demonstrate clear margins and during surgical resection. Treatment of mucormycosis, both medical antifungal therapy combined with aggressive surgical debridement and in advanced cases resection. Due to nephrotoxic potential of amphotericin B, FDA has approved posaconazole for the treatment of mucormycosis. In our study, all patients were administered posaconazole intravenous form followed by the surgery. Surgical management in our cases involving the functional endoscopic sinus surgery, which followed by oral intake of posaconazole for 3 months. Oral dosage of posaconazole continued till the sequential CT scans were disease-free post-surgery on weekly review up to 3 months. Majority of the patients were referred early stage of disease, that is within 2 weeks of post-COVID mucor symptoms. Hence, treatment initiated at earliest. This, along with the control of comorbidities, have effectively controlled the disease and reduced the morbidity involving them with salvage of surgery. Those patients who had undergone partial to subtotal maxillectomy also good response, remaining disease-free for 6 months. The surgical treatment play a key role in the management of mucormycosis. Patients presenting at early stage of disease with early treatment recovered from the disease with no recurrence. Control of comorbidities remained as a part of the patient's care, has helped in control
Stop your presentation.
process and prevention of success. Thank you, sir.
Anusha, please stop your presentation.
Sir, thank you,
Next
sir.
candidate, Dr. Balaji Rashiraj.
Sir.
Kindly share your presentation. Please start.
So good evening all. So my topic for presentation is the clinico-radiological evaluation of vascular chain status in chronic otitis media. Chronic otitis media is defined as a persistent infection of a part or the whole of the middle ear cleft, characterized by ear discharge, and sometimes, most of the times, results in a permanent perforation of the tympanic membrane. So the incidence of chronic otitis media is typically higher in developing countries because of the poor socioeconomic standards as well as also the poor nutrition. It affects both sexes equally and is seen amongst the all age groups. So it is one of the single most important cause of hearing impairment in the rural population in India. So coming to our aims and objectives, our aim of the study was to clinically evaluate the vascular chain status in patients with chronic otitis media and to correlate these findings with the radiological findings using high-resolution computed tomography of the temporal. So the objectives being, we would evaluate the vascular chain status of the middle ear by a clinical examination and to identify the pathologies of vascicles like erosions, dislocations, and fixations by obtaining a HRCT temporal, and to correlate these clinical findings with the radiological findings. So this was a cross-sectional study done at a tertiary care hospital in Telangana on 60 patients for a period of 18 months. The inclusion criteria were the patients of either gender between the ages of 10 and 60 were included, who are presented with various symptomatology of chronic otitis media like otalgia, otorrhea, tinnitus, and hard of hearing, etc., and patients who were willing for surgery and for a regular follow-up. The exclusion criteria being patients with the revision surgeries, pathologies with acute symptoms, any tumors of the middle ear, patients who are not willing for the surgery and who have lost the follow-up. So all the patients, once enrolled, would undergo a detailed history and a clinical examination, including the otoscopy, the otoendoscopic examination as well as the preoperative pure tone audiometry to find out the hearing status. Following which the patients would be subjected for a HRCT temporal bone to exclude any middle ear and mastoid pathologies and also study the ossicular chain status in detail. So after antibiotic, the medical optimization with the antibiotics, and once after the presence of a dry ear, the patients would undergo tympanomastoidectomy, and any intraoperative pathologies would be noted like cholesteatoma, granulation tissue, or any mixed type of pathology. And an emphasis will be applied to the ossicular chain for the extent of the erosion. So it would be thoroughly examined. So coming to the results of our study, so most of the patients included were between 31 and 40 years. I mean, the most common age group was between 31 and 40 years, followed by the next age group of bracket of 21 to 30 years. So predominantly they were females of 55%. And most of these patients were farmers by occupation. So in our study, the patients are presented with more than one symptom, the otorrhea being the most predominant symptom in 80% of the patients, followed by hearing loss in about 66.7% and the otalgia in 58.3%. So coming to the distribution of study population as per the deafness. So in our study, so 55% of the population had a conductive deafness, followed by sensorineural hearing loss about 7%, and also sensorineural hearing loss was about both the mixed conductive and sensorineural, that is mixed hearing loss was about 5% of the patients. So as per the degree of disability hearing impairment, so 1/3 of the patients did not have any hearing loss, and of which the patients who had hearing loss, so more 35% of them, again 1/3, more a little over 1/3 of them had a mild hearing. So coming to the otoendoscopic findings, so of the external auditory canal, we have seen the 80% of the population had discharge, 60% of them had a normal external auditory canal, like around 26.7% had a narrow canal, with 10% having a wide canal, and also a few patients, about 13% had bony overhangings and the granulation tissue. So this is one of the pictures of our patients showing discharge as well as the granulation tissue. So more than 93%, 93.3% had a perforated tympanic membrane, so enrolled in the study. So, and 80% of them, more than 88% of them had central perforation, so followed by any attic perforation, and then the very few had a marginal perforation. So coming to the degree of the perforation, again, half of the patient had the moderate degree of perforation, so it's present, so followed by a small degree in about 28.5% and the large degree, and only 7% of minimal percentage had a subtotal perforation. So in our study, again, looking at the middle ear changes, so 63% of the patients had ossicular necrosis, around 35% had granulations and other changes of edematous middle ear mucosa, and around almost 30% also had polyps in the middle ear. So coming to the high resolution CT of the temporal bone findings, so about 37%, little over 1/3 of the patients had intact ossicles, and of the patients who had ossicular erosion, so 50% of them had incus erosion. So these are the HRCT findings of the left ear and the right ear, showing almost the obstruction of the inguinomalleolar joint here. So which is followed by next by the stapes erosion in about 21%, and malleus erosion was seen in only the minority of 15%. The similar results were consistent in the intraoperative findings, where about 55% the incus erosion. So this is the incus erosion showing the lenticular erosion of the lenticular process, and this is one of the pictures showing missing of the head of the malleus. So again, here the incus was most predominantly eroded, followed by stapes in the malleus. So this is also one of the peroperative pictures showing the granulation tissue. So finally, when you look at the correlation between the otoendoscopy, CT, and the intraoperative findings, so most of our clinical features like the presence of tympanic membrane perforation, the attic involvement, ossicular necrosis, everything was significant here. So I mean, statistically, they were significant. So coming to the discussion, the chronic otitis media usually presents with perforation of tympanic membrane with ossicular erosion. In our study, the most commonly group affected were between 31 to 40 years age bracket, so which again varied with different studies. Predominantly, they were females, again had different varied results with the different studies. And so a little over half of them had conductive deafness, so which was this finding was again concurrent with the most of the study. And again, 63.3% had ossicular necrosis, and incus was the most commonly affected, and malleus was the most resilient ossicle. The results were again consistent with the majority of the study. Coming to the conclusion, so oscular chain erosion is more common feature of the chronic otitis media. The long process of incus was more commonly involved because of its because it is a delicate structure and has a less blood supply. And erosion of this oscular chain status can cause the hearing loss. So that is why we conclude that all patients of chronic otitis media should be checked preoperatively for oscular chain status with thorough clinical examination and high resolution CT of the temporal bone, findings of which positively correlate.
Last 1 minute.
Intraoperative findings in our study. These are my references. Thank you.
So any questions? Next candidate, Dr. C.H. Madhumita. Dr. Madhumita.
Yes, sir. Stop.
Are you ready?
Yes, sir. Just a minute, sir. 1 minute. It's sharing. Okay. Can you see the screen, sir? Sir,
Yes.
is the screen visible? Yes, sir.
Yes. Please
Good
do it
evening.
in the full screen.
Yes, sir. Yes, sir. Just a minute, sir. Good evening, sir. This is Dr. Madhumita. I would like to share our experiences of outcomes of facial nerve decompression in facial palsy patients. Facial palsy as a disease has serious impact on patients' life, both physically, psychologically, and socially. It can occur following various causes. Surgical intervention plays a vital role in facial nerve palsy management, and surgical rehabilitation paralyzed faces can be static or dynamic. Decompression of facial nerve can aid restoration of facial nerve functions for appropriately selected patients. The aim of the study was to evaluate outcomes of facial nerve decompression procedure in facial palsy with different etiologies. We had considered all the cases which are occurred to our which are presented to our OPD between February 2022 to August. We had come across 11 such cases of various etiologies. All the patients who needed surgical intervention for facial palsy were included. Etiologies of traumatic iatrogenic facial palsy with mastoiditis were considered. Only patients with lower motor neuron type of lesions were considered. Patients with facial nerve palsy, which can be managed medically, syndromic presentations, upper motor neuron type of lesions, patients with other symptoms of CVA.
Dr. Madhumita, sorry to interrupt
Yes.
you. We cannot
Yes,
see your screen. It is just the first slide which we are seeing.
Oh, sorry, sir. I don't know what happened. Can you see it now, sir?
Yes, but it's not the full screen.
Just a minute, sir. Let me check now, sir. Now is it visible, sir?
No.
Expand panel to show video. Sir, can you see it now, sir? Sir,
No,
am I
no.
audible, sir?
No.
I don't know what the problem is, sir, but I have put the screen on slide share, sir, but I don't know what problem I'm facing right now.
Okay, continue.
Yes, sir. Yes, sir. Patient with facial palsy following tumors were excluded, and patient who needed advanced surgical approaches were considered. For all the patient, proper history was taken, evaluated with imaging, and the following procedures were done. Facial nerve decompression only, in conjunction with nerve repair, in conjunction with cable grafting and facial hypoglossal anastomosis. Pre-op and post-op facial grading of facial paralysis was done. The results included, majority of them were male, between the ages of 40 to 60 years. Etiologies included mastoiditis, traumatic and idiopathic, traumatic being the most common. Presentation to the OPD, 4 patients presented within 1 month of onset of facial palsy, 7 after the 1 month of onset of the facial palsy. Grading of facial palsy on pre-op presentations, most of them belong to grade 4, that is 46%, followed by grade 3, 27%. Surgical approach was either by canal wall up or down approaches. Facial nerve decompression was done as a dictum for all the patients. 2 patients we had done cable nerve grafting, and 1 patient we had gone with facial hypoglossal anastomosis. Post-operative HB grading between 4 to 6 months was done, and there was improvement in 46% of the patients who improved from grade 4 to grade 3, and 9% did not show any improvement. This is a case of traumatic facial nerve palsy, stellar segment impinging on the facial nerve.
and this is an iatrogenic facial palsy case. Discussion, we had analyzed 11 patients of facial palsy of different etiologies. Male were commonly affected. Facial palsy can result from variety of etiologies, of which traumatic was the most common in our study. Most common pathology being traumatic, and tympanic segment was most commonly affected. Conclusion, I would like to conclude that patients with early intervention had better results. Patient decompression allowed has satisfactory results, and whenever we needed end-to-end anastomosis was done when tension-free approximation was possible. Facial grafting was done in 2 cases where more than 3 mm defect was seen. And management of facial paralysis generally multidisciplinary with pharmacological, neuromuscular training and surgical intervention, sir. These are my references. I would like to invite any questions, sir. Hello? Sir, am I audible, sir?
Yes, yes.
Yes, sir.
Sir, any
Sir,
questions?
Any questions?
How early you taken up the case? In your series, how early you have taken up the case?
Sir, it depended on the presentation of the patient. In case the patient came with traumatic etiology, we had intervened as soon as possible. If we suspected any trauma with, initially we started the patient on steroids, sir. After 7 days of follow-up, we had taken the patient for decompression, sir. And in mastoiditis cases, we had started the patient on conservative management initially. And in case the patient did not improve, we had taken up for the surgery, sir.
In your series, how many, what is the earliest that you have taken up? That means a few weeks or a few months or something like that?
Yes, there is a 13-day-old post-op iatrogenic injury, sir. Yes.
When you have done the nerve conductive studies?
Nerve conductive studies were not done pre-operatively, sir, because
and lack of facilities.
Yes, sir, we could not.
I understand. That is awareness, and we would have mentioned that. Okay.
Yes, sir.
It has got its own significance. Regeneration potentials can be recorded. And thereby,
yes,
prognosis can be.
Yes, we did not do, sir.
Yeah. Thank you.
Thank you, sir. So can I leave the
Next
meeting?
candidate, Dr. Banu Jennifer. Dr. Banu Jennifer, are you online?
I think she is not ready. Next candidate.
Sir, shall we move on to the next candidate, sir?
Yeah, you can.
Dr. P. Ravali. Dr. P. Ravali.
Yes, sir.
Please make sure you share your full screen, madam.
Yes, sir. Sir, is it visible, sir?
Yes, yes. Your time starts now.
Okay. Good evening, sir. I'm Ravali going to present a case series on pediatric rhinosinusitis presenting to a tertiary care center, Telangana. The aims and objectives of this case series were to study the clinical profile, frequency of complications, and treatment of pediatric patients with rhinosinusitis and its complications. This is a retrospective study of pediatric patients presenting with rhinosinusitis to a tertiary care hospital from June 2020 to August 2022. It includes only those patients who required surgical management. After admission, thorough history was taken, necessary investigations were done, followed by appropriate medical and surgical treatment and a follow-up of 6 months. Coming to introduction, rhinosinusitis is one of the most common diseases during childhood, typically following a viral upper respiratory tract infection, which is mostly self-resolving. Recovery is obtained in almost all of the cases, but however, 5 to 10% of these cases still develop complications, and the complications should be identified as early as possible and intervened immediately, as it may lead to significant morbidity like permanent vision loss, and sometimes, very rarely, it may lead to mortality also. The classification of pediatric rhinosinusitis includes acute rhinosinusitis, chronic rhinosinusitis, and fungal rhinosinusitis. Among acute, it can be either viral or bacterial. Viral is normally self-limiting, and if there are persistent symptoms of nasal discharge, cough, fever, and facial pain for more than 10 days, but for less than 12 weeks, we classify it as acute bacterial rhinosinusitis. If the symptoms persist for more than 12 weeks, we consider it as chronic rhinosinusitis. And among fungal rhinosinusitis, it can be either invasive or allergic. Invasive is extremely rare and is seen in severely immunocompromised conditions, whereas allergic is more common, and the diagnosis is similar to that of adults, that is based on Benton-Kunz criteria. Among my case series, we have encountered 13 patients who are admitted with rhinosinusitis and its complications for the above mentioned period, that's 2020 to 2022. And among them, 6 of them had acute bacterial rhinosinusitis and 7 of them were diagnosed as allergic fungal rhinosinusitis. They were usually presented between the age groups of 4 to 14 years, with a higher incidence being seen among the males. Coming to acute bacterial rhinosinusitis, 5 of them had intraorbital complications and 1 of them presented with intracranial complications and none with any local or osseous complications. Among intraorbital complications, 2 of them presented with preseptal cellulitis and 3 of them with orbital cellulitis. The kids who presented with preseptal cellulitis improved with injectable antibiotics alone, whereas those with orbital cellulitis required surgical management, that is drainage of the pus with orbital decompression. So these are the cases who presented with orbital cellulitis. The first image shows an 80-year-old kid with left orbital and facial cellulitis, and other is a 60-year-old female with right orbital cellulitis. Necessary radiological investigations were done, which shows soft tissue in the ethmoids, maxillary sinus, as well as a simultaneous MRI was taken. This shows a T2 weighted MRI of axial section showing hyperattenuation in the ethmoid regions, as well as involving the medial wall of the orbit, and as well as a mild edema in the preseptal region. Optic nerve is free, and if not intervened timely, then even optic nerve might be involved, leading to permanent vision loss. So the surgery done was endoscopic sinus surgery. This video shows the surgery being performed. As soon we can see that as soon as the pus was uncinate was retracted, lot of pus was drained. We can see the uncinectomy being done. And pus was drained. The other video shows the end of the procedure, showing cleared maxillary sinuses, ethmoid sinus, sphenoid sinuses, as well as orbital decompression, showing the prolapsed orbital contents into the nasal cavity. After surgery, the children were put under injectable antibiotics for a period of 10 days, and these are the post-operative pictures of day 3, showing significant improvement in the condition of the child. We can see happy kids and happy faces. And we have encountered one more case of intracranial complication, showing the involvement of frontal sinus with subperiosteal abscess, as well as there was mild subdural edema. This patient required only endoscopic sinus surgery followed by long course of antibiotics. But in cases of if the abscess is severe and involving large areas like cerebral abscess, subdural abscess, then a neurosurgical intervention is also required. Coming to allergic fungal rhinosinusitis, it was all the kids were diagnosed based on Benton-Kunz criteria, and the difference we have found from adults is that the disease was more aggressive in the pediatric age group, with more incidence of facial malformations like proptosis. And among the kids who have presented, 3 of them had a history of asthma also. So this shows the kids presenting with proptosis, and the CT showing characteristic unilateral involvement with hyperdensities and the mass pushing the orbit laterally, leading to proptosis. And this shows a diagnostic nasal endoscopic image showing polyp filling the intranasal cavity. The treatment for these kids included endoscopic sinus surgery to remove the inflammatory tissue, polyp, and the fungus, followed by post-operative topical steroids and nasal douching for a period of 3 months. After follow-up of 6 months, what we have seen is that there was 0 recurrence for kids with acute bacterial rhinosinusitis, whereas 3 of them with acute allergic fungal rhinosinusitis have shown recurrence. Coming to the discussion part, as I've already discussed, rhinosinusitis in children is extremely common, but mostly self-resolving, but the complications which develop are very rare. Even though they appear, timely intervention should be required, and there may be many contributing factors like anatomical malformations, inflammatory and infective conditions, and systemic conditions like immune deficiency, cystic fibrosis, and primary ciliary dyskinesia. Among acute bacterial rhinosinusitis, I have already discussed about the diagnosis. The intraorbital complication is very common, And among intraorbital complications, orbital cellulitis is common, and intracranial complications just seen are abscess formation, meningitis, and cerebritis, which requires ENT surgeon along with a neurosurgical intervention. Local complications are very extremely rare, and which includes osteomyelitis of the surrounding bone. In allergic fungal rhinosinusitis, as I've already told, pediatric AFRS has similar characteristics of that in adults, but is more aggressive in nature with higher serum IgE levels and more frequent bone erosion and malformation of facial bones. The mainstay of treatment is surgery followed by post-op corticosteroids. So coming to the absolute indications of FES in children, mostly they are treated conservatively. So when do we go for a surgical
Last 1 minute.
So when do we go for a surgical intervention is when they develop ABRS with complications or fungal rhinosinusitis, both invasive and allergic varieties, acid polyps, mucosals, or mucopiosis. So it conclude by telling that the complications of acute rhinosinusitis are rare and challenging, but the prognosis is favorable. Hence, early diagnosis and surgical drainage procedure is required. And coming to AFRS, as I've already told, it is a benign and non-invasive disease, but it can still lead to intraorbital and intracranial complications, with pediatric cases being very aggressive. Hence, endoscopic sinus surgery followed by steroid treatment is required, and there are several lacunae regarding the adjuvant treatment like immunoglobulins or usage of antifungals, for which research is still required. These are my references. Thank you. Any questions?
Sir, please unmute, sir. And her 8 minutes time is also over.
Dr. Ravli, did you rule out any sort of associated adenoiditis in rhinosinusitis in children? You have to rule out adenoiditis also, because that is always coexisting along with it. If it is there, you take up that case with coblation, what I feel from my end. Good presentation. Thank you.
Yes, sir.
Thank you, Ramesh.
Thank you, sir.
Next candidate, Dr. Asha BA. Dr. Asha. Dr. Asha, please share your presentation. Dr. Asha. Dr. Asha.
Hello. Hello, sir. Good evening, sir.
Yes. Please share your presentation.
Yeah, sure, sir.
Make it fast.
Yeah, one second. Can you see my screen, sir?
Yes. Please open your presentation.
Yeah, sure.
We cannot see your presentation.
Yes, sir. Opening, sir. Opening, sir.
Full screen.
Yeah, sure. Can you see, sir?
Yes. Your time starts now.
Okay. Good evening, everyone. Today, my paper is on biofilm and cochlear implant, our experience. So, as we know, cochlear implant surgery has both major and minor complication. Biofilm is one of the major complication, which can lead to expandation in most of the cases. So today I will be enumerating the clinical presentation of the cases we encountered, along with the procedure we followed to salvage these implants. So as we know, biofilm is a structured community of bacterial cells enclosed in a self-produced matrix. This biofilm grows on both abiotic and abiotic surface. with delayed onset of symptoms, which are not resolved by host defense mechanism and antibiotic therapy. So if you see the life cycle of biofilm, first it will get attached to a surface, then there will be proliferation, maturation, afterwards there will be spreading, dispersion to the surrounding areas. And one of the main characteristics of biofilm, if you see, it has 100 to 1000 fold increased tolerance to antibiotic. So, and another important characteristic is this bacterial cells communicate and exchange genetic material by various methods like quorum sensing and all, and it which acquire new traits, and it became more resistant to antibiotic. So commonest organism, if you see, these are Staphylococcus aureus, Pseudomonas. Sometimes the fungi can also be a cause of biofilm. If you see the incidence of biofilm in our hospital, we in about 220 cases to date, we got 2 cases of biofilm in last 6 years. So first case of biofilm was in 2018, and second recently we got almost 3 months back we got the second case. So coming to case first, he was a 2-year-old child, underwent left side surgery in 2018 and 18 April, and he presented to us with the swelling and granulation over the receiver stimulator area after 8 months after surgery. So what we did, we started multiple antibiotic, and we did regular dressing with betadine and everything, and it was unsuccessful. So we decided to take the baby for debridement. And after debridement, we did even secondary suturing. Those were not successful. So we had 2 options. One is to explant the implant as recommended by many surgeons. Another option was to salvage the implant. So we opted the second one. We did a salvage surgery. And our second case was a 2-year-old female baby underwent bilateral cochlear implant surgery in December 2021. So almost 6 months back. Then afterwards, in June 2022, she presented with the same way as the first case, and we did everything in similar way. We did regular dressing, we used antibiotic, and we used an antiseptic that is known as prondazan. It contained hexenamide and betaine. So we did dressing with even this prondazan, everything, but everything was unsuccessful. So we decided on salvage surgery. So salvage surgery, if you see, usually we do what we have done. We did an extended posterior incision, and we debrided the receiver stimulator area and even receiver stimulator, and we relocate the receiver stimulator anteriorly, and we elevated temporal muscle flap, and even we cleaned thoroughly. We washed the area with hydrogen peroxide, betadine, and antibiotic like vancomycin. Then we close the skin in layers. So if you see this picture, you can see this is and we asked the help from a plastic surgeon, and you can see the extended posterior incision, and you can see the superficial temporal artery marking, which supplies the temporal muscle, and you can see the receiver stimulator area. And what we did is we actually debrided this, even removed the necrotic tissue, necrotic skin, and we debrided the whole area. And this biofilm usually seen on this bed of receiver stimulator area. That also we thoroughly cleaned, washed with vancomycin, betadine, hydrogen peroxide, and we relocated this receiver stimulator anteriorly, and we fixed with titanium screws, and we elevated this temporal muscle, this anteriorly based temporal muscle, and we covered it. Our implant is covered with temporal muscle, and we sutured the skin in 2 layers. We used temporoparietal fascia and skin. So, and we kept drain for longer, around 5 to 7 days, as advised by plastic surgeon. So this is the picture of a recent salvage surgery, 3 months after surgery. Till now, our child is doing well. So using the above procedure, we could successfully salvage the first case. after 3 years of salvage surgery, patient is doing with normal outcome. Our first case, till now he is doing well. So if you're reviewing the literature, most of the recommendation were for explantation. So if you see this study, Neelam Ved, she also advised for early explantation. And another study is major related to major skin flap complication. Biofilm was one of the major complication, skin flap complication. In that, about explantation rate was about 80%. Another study by Shalabh Sharma, he reported one case. He could salvage the implant by using antibiotic and tea tree oil. This this local antiseptic solutions can be used. Nothing conclusively proved till now. And another study by Neeraj Suri, he had 2 cases of biofilm. One case he could salvage with antibiotic and betaine surfactant, and one case he expanded. So though overall recommendation is for explantation, based on our limited experience of our 2 cases, we strongly recommend to salvage implant before
Last 1 minute.
Planning for yes, sir. So this is the conclusion. In all cases, we can try salvage surgery, can be decided on explantation. So that's all, sir. Hello, so can you hear me, sir?
Yes. Are you done?
Hello? Yes, sir. Yes, sir. I'm done, sir.
Sir, any questions, sir?
So any questions, sir?
Asha, for your biofilms, there are many methods have been recommended. Did you have any experience with Monica Honey?
Sir, local antiseptics are recommended by many authors in literature, sir, but nothing conclusively proved, sir. We tried actually only Prondazan, but it was unsuccessful, so we didn't go for any other tricks, sir. Monica honey and even some
baby oil, constant irrigation.
Yeah, tea tree oil, and so many are recommended, sir, but nothing is proven, sir.
Has been recommended.
Yes, sir. Yes, sir. We tried Prondazan, sir. That was unsuccessful.
Good. So you saved because of the cost factor.
Yes, sir.
You
We
made
could
it
salvage the implant, sir. Yes, sir. Yes, sir.
Right?
Yeah.
Next candidate, Dr. Aarti Singh.
Hello, sir. Just a second, I'm sharing my screen.
Your time starts now.
Good evening, one and all. I am presenting a case of a surgeon facial palsy in the COVID-19 era. SARS-CoV-2 is a virus, and its clinical manifestation as COVID-19 is an ongoing global pandemic. Although this disease shows remarkable respiratory symptoms, its clinical presentation is not pathognomonic. The symptoms range from mild disease such as fever, cough, malaise, etc., progressing towards multiple organ failure in advanced stages and further leading to death. The patients with COVID-19 have shown various otorhinolaryngological manifestations such as anosmia, parosmia, cacosmia, agusia, dysgeusia, and sudden onset facial palsy. The sudden onset unilateral lower motor neuron type of peripheral facial nerve palsy cases have seen a surge during the COVID-19 era. Aims and objectives. SARS-CoV-2 infection has been associated with a wide range of symptoms, the most common being fever, cough, and fatigue. Nonetheless, coronaviruses are known to have neuroinvasive propensity, and as with SARS and Middle East respiratory syndrome, current evidence suggests that COVID-19 pathophysiology may also involve the nervous system. So the aim of the study is to determine the incidence of sudden facial palsy in patients affected with SARS-CoV-2. Bell's palsy has been associated with various other viral agents as well, such as HSV1, varicella zoster, Epstein-Barr, cytomegalovirus, Utsu virus, and HIV. Material and methods. The study was conducted from December 2020 to 21 in the Department of Otorhinolaryngology at a tertiary care hospital. It was a cohort study. Duration was 12 months. Sample selection. The participants were selected by convenience sampling. Sample size was 60 patients. Inclusion criteria. Qualitative RT-PCR positive cases of SARS-CoV-2, sudden onset facial palsy within 8 weeks of COVID-19 infection, patients of the age group of 18 to 45 years, previously healthy patients with no medical comorbidities.
Exclusion criteria were RT-PCR negative patients of suspected COVID-19, upper motor neuron palsy, any associated neurological symptoms, history of ear discharge, previous history of Bell's palsy, recurrent COVID-19 infection, history of medical comorbidities, history of ear surgery or head injury, history of any head and neck surgery, and age group less than 18 or more than 45 years. These are the pictures of 2 cases I have taken. So the results, a total of 60 patients with COVID-19 were identified. These patients were previously healthy. Mean age was 40 years. That is between 18 to 45 years. 32 patients were male and 28 were female. 5 of the male patients and 7 of the female patients presented with sudden onset facial palsy. Average duration of presentation was 5.3 days after initial symptoms of COVID-19. Of the 12 patients, 2 had earache, 2 had tinnitus, and 1 had both earache and tinnitus just prior to the development of facial palsy. 8 patients had grade 1, 1 patient had grade 2, 1 patient had grade 3, and 2 had grade 4 facial palsy using House-Brackman scoring during the initial examination. The facial palsy resolved after a 4-week treatment course in 10 patients, and residual palsy was seen in 2 patients. Treatment included antiviral therapy, acyclovir, tapering dose of oral steroids, that is prednisolone, facial physiotherapy, artificial tear eye drops, and protective eye patch during sleep. So these are the results. Males, 15.6% of the males had facial palsy. 25% of the females had facial palsy. They were having otological symptoms in 8.3% cases, and residual palsy was remaining in 16.7% cases. This is the distribution in males, females, and the prognosis. This is the distribution of otogenic symptoms, and this is how most of the patients had grade 1 facial palsy according to House-Brackman score. Associated symptoms, dysgeusia was present in 58.3% patients, anosmia in 66.7% patients, otalgia and tinnitus in 25% respectively. Discussion, 20% of patients in this study developed sudden Bell's palsy post-COVID. 15.6% males were affected and 25% females were affected, which means propensity in females was higher. 16.7 patients had earache and 16.7 had tinnitus and 8.3 had both, indicating viral otogenic facial palsy. 66.7% had grade 1 facial palsy, whereas 16.7 had grade 4 and 8.3 had grade 2 and 3, which was seen, and it implied less severity of facial palsy associated with COVID-19. 83.3 patients, 3% patients recovered with 4-week treatment regimen, while 16.7% had residual palsy. A chi-square test was used for statistics. The probability level of less than 0.05 considered as statistically significant, and it showed a p-value of 0.002. So this study is indicating a positive correlation between lower motor neuron facial palsy and SARS-CoV-2. Conclusion, SARS-CoV-2 has shown propensity toward neurological damage. Central nervous system diseases such as debilitating encephalopathies and ischemic insults have been described as complications of initial COVID-19 pneumonia. However, a study by Mayo et al. Recognized peripheral involvement with hypogeusia 82% and hyposmia 86%, classified as common symptoms of SARS-CoV-2 infection. According to this study, there is increased incidence of Bell's palsy in patients of COVID-19. It is important for clinicians to be aware that facial nerve palsy may be an initial presentation of the disease, and Bell's palsy can be a sign of COVID-19 infection and should not be missed. These are my references. Thank you.
Thank you. Any questions, sir? Sir, she is the last candidate, sir.
Any questions?
Ramesh, sir? Sir, we are done with the candidates, sir, presentations. One person, Dr. Vrinda Ullas Nair is absent, sir. And Dr. Chaitanya PM is absent, sir. And Jennifer Banu. Ramesh, sir. Sir, we are done with the candidates, sir. Total of 28, of which 3 people are absent, sir.